Okay, everybody, we're going to get started. It's a little after 1. Welcome, everybody. Here, I'm going to use a little gavel here. Okay, we're going to get started. We've got a number of bills today, and we're going to start with a bill with quite a number of witnesses. Senator Kelly, Senate Bill 890. And so, Senator Kelly, if you want to go up to the podium, and then I'm going to call your panel that can sit up at the witness table. We've got Congressman Anthony Brown here. Why don't you come up here, Congressman? Sit up at the table here. We've got Robin Elliott. We've got Dr. Reagan McDonald Mosley, and then finally Lynn McCann. So, if the panel of 4 folks that I just described can go up and take a seat, and the way we're going to do this, we'll start with Senator Kelly, who will present the bill, and then her panel of 4 will each get an opportunity to weigh in, and then we'll take it from there.
Thanks a lot, colleague.
So Chair Kelly, you're going to lead it off on Senate Bill 890.
Thank you, Mr. Vice Chair. I'm pleased to present to you, along with my co-sponsors, Senator Feldman and Hedelman, the most important piece of legislation on reproductive health care in 30 years. Back in 1991, this body enacted legislation that codified Roe v. Wade. Maryland voters overwhelmingly ratified the legislation in 1992 when it was placed on the ballot as question 6. Many of us may think of Maryland as a safe state for abortion care. Our committee knows very well, as we review countless pieces of legislation each session on health care, that access is far more complicated than the legal right to services. For any health care service, access means having enough providers, sufficient insurance, and the means to navigate barriers such as transportation, taking time off from work, and child care. Access to abortion care is more challenging than any other health care service because of the hostile environment faced by both patients and providers. Patients often have to walk past protesters who are increasingly aggressive, even sometimes taking photographs of license plates of people visiting the clinic. Providers report that patients sometimes think abortion is illegal, even in a state like Maryland, because of all the news reports about bans and restrictions in other states. Abortion care providers, unlike any other health care providers, face harassment, threats, and even violence at work, and sometimes even at home. What has been the impact of the environment on abortion care access in Maryland? We know from data from the Guttmacher Institute, which surveys states every few years, most recently in 2017, that the number of abortion providers in Maryland has fallen. Between 1991, when we codified Roe v. Wade, and 2017, the number of abortion providers fell from 52, that was the max, down to 44. Today, over 2/3 of counties in Maryland do not have any abortion provider. This means that women outside of the Baltimore-Washington corridor must travel far and sometimes even to neighboring states for abortion services. When we compare Maryland to states in the Northeast, which have abortion right laws similar to ours, Maryland is the worst state for abortion access geographically. Even in a very rural state like Maine, almost 70% of the counties have abortion providers. Maryland is the exact opposite, where about 71% of our counties do not have any provider. As policymakers, our question is, what are we going to do about abortion access, and when should we take such steps? My fellow committee members, I think we have no other choice but to take action now. In June, the U.S. Supreme Court will decide the Dobbs case, where the Mississippi Attorney General has formally asked the court to overturn Roe v. Wade. All the legal predictions are that if Wade is not overturned, it will be severely damaged. 26 states are poised to outright ban or severely restrict abortion. The impact will be devastating to women in those states and will have a severe impact on access in neighboring states. We already have a sobering preview of this reality. In the month after Senate Bill 8 went into effect in Texas, the number of abortions in Texas dropped by 50%. Women who were able to go out of state traveled hundreds of miles for services, sometimes even thousands of miles, as we saw women from Texas seeking services in Maryland. The states that surround Texas are overwhelmed by requests for abortion care appointments, increasing waiting time for both in-state and out-of-state patients to as long as 19 days in Louisiana, 20 days in New Mexico, and 23 days in Oklahoma. These numbers are deeply concerning, and we cannot ignore them. We need to think about what abortion care access will be like in Maryland after June's Supreme Court decision. Marylanders are already underserved when compared to our northern neighbors. We need to act now so that we can protect access for everyone who will need abortion care. And we're talking about even 10 and 11-year-old girls who are victims of incest and of rape. And we don't want to rely on the advice of the newest Supreme Court justice who recently said, it's just amazing. Let the child have the baby, carry it to term, even if she is a victim of incest or rape. And then she can just put it up for adoption. And when I think of anyone who has been already violated in a way that a child might, or a woman for that matter, when they are a rape victim or a victim of incest, and to think of the physical and the psychological progression of what must go on for a person in that circumstance, where their very body becomes almost after the fact a reminder daily of what they have already suffered and the violation that they have had to endure. And to say to a child victim, or to any woman for that matter, just put it up for adoption. We know that many of the people that we hear every year need to serve with all kinds of services that they cannot otherwise afford, are people who simply don't have the economic means and the legal assistance that it would take to put somebody up for adoption. Can you imagine a 9 or an 11-year-old girl trying to go through that? And would you expect a healthy human being to come out on the other end, physically, psychologically, spiritually, or in any other fashion? So today, I present to you a truly urgent bill, Senate Bill 890, Abortion Care Access Act. The provisions of this bill are not new or novel. The bill embodies the same tried and true strategies that we have used to address access issues for health care services in other venues. First, the bill includes strategies to increase the number of qualified abortion providers. Long ago, our state successfully embraced the strategy of utilizing nurse practitioners, nurse midwives, and physician assistants to increase access to primary care, to specialty care, to prenatal and delivery services. But Maryland has an outdated legal restriction on utilizing these same providers for abortion care. With this bill, we would lift that restriction and join the 14 other states that allow advanced clinicians to provide abortion care. Our physician community supports this bill, as you will hear from the Maryland chapter of the American College of Obstetrics and Gynecologists. The bill also supports clinical training, as we know that physicians and nurse practitioners who move to Maryland from states like Texas or Mississippi will not have had abortion care as a part of their clinical education. We can also use this clinical training program to ensure our abortion provider community is as diverse as the communities they serve. Second, the bill will ensure that all Marylanders, whether insured through private plans or through Medicaid, have equitable access to abortion coverage. In private insurance, all plans, except those with legal exemptions, including religious exemptions, and we do respect religious exemptions in Maryland, will cover abortion care without cost sharing or deductible requirements. We know from research that women delay care when they have such cost-sharing requirements. Senate Bill 890 will make Medicaid coverage permanent and not subject to political debate in the budget bill every single year, as is now the case. It is simply not fair or equitable to make health coverage for low-income individuals subject to such annual debate. That's really discriminatory, even if that is not our intent. We will also eliminate very outdated and stigmatizing policies that have been enshrined in our budget bill since 1979. For example, Maryland requires rape survivors to file a police report in order to get abortion coverage in Medicaid. If a young woman has already been so terribly violated, should they have to go down to the police station as if they, in fact, are the violator and file a police report in order for the state to give Medicaid coverage so that they don't have to spend their lives going through the psychological and the physical and the economic trauma of needing to take care of or to provide for the outcome, really, of the harm that was initially done to them when they were so violated. Imagine the trauma experienced by an 11-year-old victim of rape or incest forced to go down to the police station to file a report. The provisions of Senate Bill 890 will protect access to abortion in Maryland. Passage of this bill will ensure that Maryland has sufficient numbers of licensed practitioners and that Maryland has sufficient insurance coverage for patients needing abortion care. Access to abortion care has already been impacted by bans in other states, and the current Supreme Court is likely to make things worse. When the court acts in June, it will likely abandon its decades-old stance on Roe v. Wade. One other thing that I want to just say, and I didn't write it down, but when I did my second master's degree, which was at Purdue, one of the married couples who lived in married student housing next to where I and my husband were found herself pregnant. And she was having such terrible problems with the pregnancy that just seemed to baffle everybody. It turned out that the fetus was not in the uterus, but was in the fallopian tubes. So this is another situation which sometimes could happen. The choices before her were to keep that fetus in that fallopian tube until it birthed and the fetus was lost naturally, I guess you could say by nature or by neglect, and she would die. Or to get an abortion early, to not have that kind of an outcome. So we've got to remember also fetal abnormalities. And in a case such as the one that I became familiar with, it would have killed the would-be mother as well as the fetus anyway. In light of all of these concerns, I seek your expeditious support of Senate Bill 890 with the attached technical amendments.
Okay, thank you, Madam Chair. Before we go to the panel, why don't we see, does anybody have any questions for Chair Kelly? Okay, seeing none, Madam Chair, we're going to now go to the panel. We're going to start with Congressman Brown. Normally we have a 2-minute rule, but you know what? As United States Congressman, we'll give you time you need.
Well, Mr. Chair, Vice Chair, I'll remind you, I'm in the U.S. House of Representatives where we honor time limitations, not the U.S. Congress that likes to filibuster, so I think I'll stay close to 2 minutes. Thank you, Mr. Chairman. I am Congressman Brown. I'm here to testify in support of SB 890, the Abortion Care Access Act. I'd like to thank Chairwoman Kelly, Vice Chair Feldman, and Senator Hettleman for introducing this important piece of legislation. I want to commend the Chair for a compelling presentation of the bill. I also want to thank the committee for allowing me to testify today. It should be undeniable women have a right to make decisions about their health, bodies, and lives, yet that right and that choice are at risk. Last year, states enacted more than 90 reproductive health restrictions, the most since the landmark case of Roe v. Wade in 1973, including, of course, the notorious Texas law creating a bounty-like system to intimidate women and health care providers, which effectively banned abortion before most women even know they're pregnant, and refuse to make exceptions in cases of rape or incest. This year, the Supreme Court, as we heard from the sponsor, would further erode the protections of Roe versus Wade. These restrictions are extreme, they're dangerous, and disproportionately affect underserved communities and women of color. The fight to protect women's health care is a nationwide priority in Congress, in the courts, and here in Maryland. In Congress, the House passed the Women's Health Protection Act to codify the protections and rights under Roe versus Wade into law. The House of Representatives has also passed legislation similar to the bill you are considering today to expand reproductive health services and contraception. And we've worked to ensure that laws around reproductive health care are grounded in medical science and equity. Should Roe versus Wade be overturned and weakened, Maryland needs to be ready. We need to have health care infrastructure ready to support an expected increase of women seeking reproductive health care in our state. Today, many counties in Maryland, as we've heard, do not have a single abortion provider. We need to ensure that we have an expanded pool of trained health care professionals in place and make sure that reproductive health services are covered by women's health insurance. It's time to recognize reproductive health care is a critical and core health care service. The fight for reproductive health care in Maryland and around the country is a fight for civil rights, equity, racial justice, and economic empowerment. Maryland needs to be prepared, and we need to lead with our values. Mr. Chairman, Madam Chair, Mr. Vice Chair, the Abortion Care Access Act is a necessary and crucial step forward in this effort. Thank you.
Okay, thank you. Any questions for Congressman Brown? Okay, seeing none, we'll go to the rest of the panel. We'll go through all 3 of the panelists, and then we'll open it up for questions. We're going to start with you, Robin Elliott. 2 minutes.
Good afternoon, Robin Elliott. I am here today on behalf of Planned Parenthood of Maryland, and I am so honored to be able to work with such a wonderful bill sponsor, Chair Kelly. You described that bill so well. I just wanted to add some background information to support what Senator Kelly relayed. Maryland is behind in terms of numbers of providers. In your packet, you have this map. This shows that Maryland is here. All the states northeast of us who have similar laws to us have far more counties with abortion providers, including Maine, which is our most rural state. I want to speak a little bit about the history of Medicaid. Many of you may know I'm a former budget analyst, and that language in the Medicaid budget bill has been in since 1979. We may wonder where it comes from. In your packet, you have the form that physicians have to fill out to meet those requirements. Well, I went back in the law that you repealed in 1991 contains the very same provisions that you are requiring in that budget bill language for women to do. And that is simply that they must have a medical justification. It must be justified by a physician, or in cases of rape or incest, there must be a police report. And the decision is left up to the physician. It is not up to the woman in consultation with her provider. That language is from 1979. We really ask in this bill for Medicaid coverage to be equitable and equivalent to the coverage that women have under private insurance. Thank you.
Okay, thank you, Ms. Elliott. We're going to go, we'll just go down the row here, and then we'll open up to questions.
Thank you so much for allowing me to be here to speak to you today about this important bill. My name is Dr. Reagan McDonald Mosley, and I'm an obstetrician gynecologist. I've dedicated my career to ensuring that all people, regardless of their income or race, have the power to decide when, whether, and under what circumstances to have a child. I moved to this great state 14 years ago solely to receive specialized training in complex family planning at Johns Hopkins Medical Center, one of the oldest and best-known family planning fellowship training sites in the country. Although I did not realize this at the time, my path was very uncommon. What is far more common is a shortage of training opportunities for abortion care. This leads to a paucity of services. Despite being a shining star in many respects related to health care, Maryland simply lags behind related to abortion access. As you have heard, 71% of counties in Maryland lack an abortion provider. Allowing advanced practice clinicians to provide in-office procedural abortion would dramatically increase the potential workforce. Moreover, there's ample evidence in other states to demonstrate that advanced practice clinicians can safely provide abortion care with equitable outcomes to physicians. The healthcare landscape is changing rapidly. The needs of our communities are clearly outpacing our ability to provide care in lots of contexts. We rely on advanced practice clinicians to provide indispensable services in other contexts, such as medical subspecialty care and mental health care. Abortion care should be no different, especially when advanced practice clinicians have shown that they're capable of learning the skills and safely providing this important care. Lastly, it's obvious that abortion access across the country very much hangs in the balance due to the impending Supreme Court case. This bill would allow us to proactively invest in a pipeline of capable providers who can deliver quality abortion care to people in Maryland. Make no mistake, there already has been and will continue to be an influx of patients from out of the state, which will only cause further delays for accessing care for Marylanders. You have an important and unprecedented opportunity to act now and make this all different. You have an opportunity to invest in equity and an expansion of care. I urge you to support this important legislation. Thank you so much.
Okay, thank you. We'll go to Ms. McCann, complete the panel.
Sure. Hi, everyone. My name is Lynn McCann. I'm testifying on behalf of the Baltimore Abortion Fund today. Thank you all for having me. The Baltimore Abortion Fund is a nonprofit organization. We work to operate a confidential helpline to connect people with financial and logistical support so that they can actually access an abortion. We've been working for the last 8 years to serve both people in Maryland and also people who are traveling from out of state to Maryland for care. And we've seen throughout all of these years that there are significant financial, logistical, and social barriers that prevent people from actually getting an abortion right here in Maryland. We're excited to testify on behalf of this bill because it's closing and removing some of the barriers to care that people in Maryland are already facing. As Robin mentioned and other folks on the panel mentioned, we already know that there is a geographic equity issue for abortion care providers in Maryland. A lot of the people that we serve are from the Eastern Shore and Western Maryland, where they do not have enough providers and are already traveling long distances to Metro Baltimore and Washington, D.C. for care. Our organization is also bracing itself for an influx of requests for support from people traveling from out of state. It's part of a growing trend that we've already seen. Requests from out-of-state folks have grown from 40% of overall calls to 50% in this past year alone, and we know that that number will increase exponentially if Roe is overturned or weakened in the spring. The increase in requests for support from out-of-state folks will strain the availability of resources and care for Marylanders, which is already inequitable and insufficient. So we're excited for this legislation, which will increase the number of qualified medical care providers who are able to perform this time-sensitive and essential health care so that Marylanders can continue getting the care that they need without any reason to delay. Thank you.
Okay, thank you. Any questions for the panel? Senator Kramer.
Yes, thank you, Mr. Chair, and thank you all very much for your presentations. And just quickly, Dr. McDonald-Mosley, can you share with the committee the number of patients that you see that come from rural areas and what some of the barriers may be for them in seeking your service?
Yes, thank you for that question. I don't have the numbers of the exact number of patients, but we can follow up with the committee with those numbers based on Planned Parenthood of Maryland's geographic distribution. But I can tell you anecdotally from providing care in Maryland for over a decade that, the majority of the patients do come from the metro areas, but we do have a number of people who travel long distances from Western Maryland on the Eastern Shore, sometimes upwards of 6 hours, which can cause significant delays in them being able to get an appointment and access care. So having more proximal care would make a huge difference in terms of their quality of life, and also being able to just get care from their, provider in their own community can make a huge difference.
Thank you for that. And quickly, Ms. Elliott, if you would mind, my eyes not being quite what they once were, you pulled out that little map that you have there and made a quick reference to it, and I think I saw Maine up there at the very top in a perhaps different shade of color.
It's very
Then-
colorful.
Yes. So, and you were making reference to the fact that in Maine there is greater access. Is that correct? And if so, can you share with us how they are accomplishing that?
Yes, so Maine is almost the exact opposite of Maryland. In Maryland, there are 71% of our counties, this is according to the Guttmacher Institute, that do not have a single abortion provider. In Maine, it's 69% of counties have an abortion provider. And the reason that has happened is that Maine changed its law to recognize nurse practitioners and nurse midwives as providers. And those providers, as you all have utilized them with other healthcare initiatives, whether it's behavioral health or primary care, those providers are embedded in rural communities. So that was really a game changer for Maine.
Interesting. Thank you for sharing that. And one last question while you got the map out. What do you anticipate is likely to be happening with states that are contiguous to Maryland? And are they going to be possibly increasing restrictions? So would you mind just opining for a moment on that issue?
Thank you. So we know that 26 states across the country are poised to ban or severely restrict abortion, maybe as soon as June. And we see patients from Texas. Immediately surrounding us, there are threats. West Virginia has a single abortion provider now. They are on the brink of passing a Mississippi-style ban at 15 weeks. And we believe that as soon as the Supreme Court lets them, they will ban abortion. To the north, in Pennsylvania, the legislature there is endeavoring to put a constitutional amendment on the books to ban abortion. And then to our south, in Virginia, which has changed immensely in the last few months, the Attorney General, the governor, and the lieutenant governor have all declared it a priority to restrict abortion access. So we consider in our jurisdiction, in our region, that we may have a crisis by this time next year, as soon as the summer.
Well, okay, thank you for sharing that with the committee. Very much appreciated. Thank you, Mr. Chair.
Okay, before we go to the next question, I should have mentioned this bill's jointly assigned to the Budget and Tax Committee, and we're joined by Senator Griffith on behalf of the Budget and Taxation Committee. And so with that, we're going to go to you, Senator Benson.
Yes, thank you very much. I'm from Western Maryland. I'm from Hagerstown. And one of the common complaints that we get is that the access for people, for women up in that area is almost zero. Can you all speak to that? And what are you all doing in the way of giving support to those women who are seeking your service?
Senator Benson, I love that question because I grew up in Hagerstown.
Really?
Yes, I went to North High. So,
Well, I won't hold that against you.
so in Hagerstown, as you may know, there is an abortion provider that is open about 1 day a week because that physician who provides services splits his time between 3 other sites across the state. And in front of that clinic, as you might know, because you may have driven past it, there are always protesters. I have had personal experience with this. When I was living in Hagerstown, someone asked me, and I drove them to Harrisburg, Pennsylvania, to get abortion care because it wasn't easily accessible in Hagerstown, and they did not want to walk past the protesters. Hagerstown is the furthest west. So if you live in Allegheny County or Garrett County, you might be driving as far as Pittsburgh for services. What this bill does is there is an abortion care training program. And the idea is that we want to train physicians, nurse practitioners, nurse midwives who are in those rural areas so that they can provide abortion care services in their own practices. And we think this will really help the rural parts of our state. And of course, being from Western Maryland, I particularly hope it helps Western Maryland because we should not have to have Marylanders driving to Harrisburg or driving to Pittsburgh for services.
And if I might just add, the research about sort of who has abortions, it's not people who have abortions and people who don't, it's everyone. But if we look at sort of the demographics, people who have abortions are more likely to already be parents, right? So they're having to deal with coordinating childcare, to travel long distances. They're more likely to be navigating the world with lower incomes, and they're more likely to be people of color. They're more likely to be the people who have the most barriers to accessing care. So this really is an equity issue for the people in our state.
The sad part for me is that we have, when I think about my hometown, it's been just kind of sad for women who become pregnant and they begin to think about all of the responsibilities that are involved, and then they develop mental health issues, and it just goes on and on and on and on. There's child care, and they start thinking about. And we have had, up in Hagerstown, a number of our women who have resorted to attempted suicide, all kinds of things, because they don't have the money. They don't have the money to go to Harrisburg or to go outside of the state. And that has created just insurmountable problems for those poor women who are up in Hagerstown. I'll have to tell you that it has been very tragic for a number of those women. Thank you.
Okay, we've got Senator Reedy.
Thank you, Mr. Chairman. I apologize. I had 2 bills in another committee to start the hearing, so that's why I came in late. And this was addressed earlier, forgive me, but is the purpose of this bill, part of the purpose of this bill is to allow non-physicians to end pregnancies, correct?
Correct.
So can we talk a little bit about what other states do that now? Did you give a list earlier, or?
I am happy to provide that list. There are 14 states.
what qualifications do those states require instead of being a physician?
So
I understand it could be different to different states, but.
yeah, of course, licensure gets a little different, but generally, the requirements are that it has to be within your scope of practice, and that you have to be licensed or certified. The certification is because advanced practice nurses are certified rather than licensed. And so the states that have done this are California, and sometimes I should say they've legislated it. There's been an AG's opinion. We have an AG's opinion in our state that allows medication abortion but not procedural care. Or sometimes the law just doesn't restrict it. So, and those states are California, Colorado, DC, Maine, Massachusetts, Montana, New Hampshire, Oregon, Vermont, Virginia, Washington, West Virginia, and I'm adding it, it's a little bit out of order because they're very new. In New Jersey, their Board of Medicine, it was a regulatory restriction that they lifted in December.
So in those, great, I appreciate the answer. So in those states, what kind of certification then, do they have to undergo any sort of special certification for performing these kinds of medical procedures, or is it just that it's in their scope of practice?
That's a great question. Every law is a little bit different, but generally it's within their scope of practice. So just like for a nurse midwife,
Is it continuing education is what I guess I'm asking. Is there like a continuing?
Yes, every whether you are a physician assistant, a nurse practitioner, a nurse midwife, or nurse certified midwife, I may have missed one, but all of them have rules either in statute and in regs, they're all intertwined, that require you to be competent for the care that you provide. So whether you're providing labor and delivery services, or whether you're providing abortion care or miscarriage management, any of those services, you are required to be competent before providing that care.
And I have some other questions that I'm hoping I'll listen to more testimony throughout the hearing. Part of I think, correct me if I'm wrong, we talked about the genesis of this bill is we talked about nationwide some different things that are happening. Do we believe there is an access to care issue? You believe there's an access to care issue even in Maryland, even now? Putting aside the issue of funding for abortion and abortions and what any of us feel about that issue, believe about that issue, a non-lapsing fund of $3.5 million, how do we define success? Is there a goal of the number of practitioners we'd like to reach? Can we define success for this?
That's a great question. So just a little description of what's in the bill is that the Department of Health would have to set up a program. We know they don't run training programs, so they would have to give the grant to an entity, and there are a couple across the country that have managed grant programs for both hospital and community-based care. When MDH allows that grant, I would certainly expect that they would put outcomes and goals and measurements. We didn't want to presuppose what those were, but it's full expectation that they would put those requirements in.
Because we're saying there's a problem. You're saying there's a problem, but it doesn't sound like we maybe have the data to say this is the number of people who aren't being serviced for what they need versus. I think it'd be very important to have some real clear metrics if we're going to, if we're going to put money towards something for it to say, well, this is the goal that we have. I mean, I don't know if you can state what the goal you would have.
I think the goal that we would have is maybe our Maryland here would become pink in our map, that we really want to make sure that more counties have abortion providers available. And that doesn't mean necessarily a Planned Parenthood clinic or a Whole Woman's Health. We're really looking to have abortion care integrated into other parts of healthcare systems. So certainly a nurse practitioner, a birthing center, a family medicine physician in a rural area, certainly can offer some of these services. And that's really what our hope is to train people to go out and integrate it into whatever care setting they practice.
You're speaking, this is my final question, Mr. Chair. You're speaking about, that's interesting, the integration. I view any time an abortion takes place as being something that is a tragedy, is a bad thing. Now, and a lot of people feel that way. And a lot of people that I know that feel differently about the issue of abortion still feel that it's not a good thing when it has to happen, right? I know that there's probably differing opinions about that with the folks sitting at the table, and that's fine. What could we do to try to implement in this bill? I don't support doing this, but what can we do to try to implement this bill to say, how can we try to be sure that we're giving people better options so that we don't have as many unwanted or unwanted pregnancies? I mean, what can we do in a collaborative way on this issue? Is there any hope for that?
So, I certainly think you've had legislation before you, and I think there is lots more room for improvement in terms of contraception access, also preconception care, so making sure that we're taking care of women so that they're healthy long before they become pregnant.
Well, we've done some work on the Medicaid side.
So all that prenatal care, but even before prenatal care, before they're pregnant, making sure that people are healthy, because if you're healthy and then you become pregnant, you're much more likely to have a healthy pregnancy. So, Senator Reedy, I think there is lots of middle ground here that everyone wants our Marylanders to be healthy, and we want those individuals who desire to be pregnant and to have children to be able to have them in a healthy manner. And this body has done incredible work in the past couple years in terms of increasing prenatal care access, and would very much appreciate working with you on those issues.
Thank you, Mr. Chairman.
Okay, Senator Hershey, and if you have a specific witness you want to direct your question to.
Yes, thank you, Mr. Chairman. I know there's going to be a lot of polarizing testimony today, but Dr. McDonald-Mosley, using the expansion of abortion rights as a job creator is pretty sickening. And I know we're going to go into some probably deep places today, but I think that was a little bit too low. Thank you.
May I respond?
I think that was more commentary.
Okay.
Just, why don't we just leave it at that? Okay, so any additional questions for the panel? Okay, seeing none, I think from this point, thank you very much for your testimony today. We're going to sort of alternate between proponents and unfavorables at this point, but we'll start with 4 witnesses unfavorable, and then we'll go 4 witnesses unfavorable. So when I call your name, come up to the witness table. Gracie Nichols, Jennifer White, Lisa Jordan, and Rajana Rajana, last name beginning with G. I don't want to botch up the name, so I'll leave it there. But we're going to start with Ms. Nichols, and we should have 4 folks, 4 seats, 4 witnesses. So Ms. Nichols, why don't you lead off, and then we'll go to Jennifer White and Lisa Jordan, and then we'll do cleanup. So Ms. Nichols, why don't you start, and we're under a 2-minute rule.
Good afternoon. My name is Gracie Nichols, and I am a nurse practitioner at a large academic medical institution in Baltimore, where I provide abortion-related care with a team of physician and nurse colleagues. I am pleased to be here today to give testimony in support of Senate Bill 890.
Yeah, could you pull the mic up a little
Yep.
so we can hear you, because we've got to catch you on the mic.
Is that better?
Yes, much better, thank you.
I'll focus my testimony today on insurance-related barriers to abortion care. I would like to start by sharing a story of a patient who came to our hospital in need of abortion care. She had a high-risk pregnancy and required a procedure in a hospital setting due to the complex nature of her case. She had private insurance, but was devastated to learn that she would need to pay over $3,000 out of pocket to meet her deductible. She lived 2 hours away, and her care would involve multiple visits, time off work, and lost wages, all of which added to her financial stress. Fearing that she'd be plunged into medical debt, she delayed her much-needed procedure. Ultimately, one of her coworkers offered to personally cover her deductible so that she could get the care that she needed. Patients can face significant out-of-pocket costs for abortion care, even with insurance. In one study, 25% of patients with private insurance had out-of-pocket expenses of $200 or more. Over half of patients seeking abortion delayed care to gather resources to cover cost. Patients with Maryland medical assistance or Medicaid can also face insurance-related barriers to care, as you've heard from earlier testimony today. Although patients have coverage for abortion services if they fall into an eligible coverage group, these groups are outdated, ill-defined, stigmatizing, and confusing. They often result in delays to care and very often in PED referrals. This legislation would protect access to abortion in many important ways, including by requiring state-regulated private plans to cover abortion care without cost-sharing or deductibles, and by ensuring that patients with Maryland Medicaid have equitable coverage. Please support Senate Bill 890. Thank you.
Okay, thank you. We'll go next to Ms. White.
Yes, good afternoon, everyone and members of the Senate Finance Committee. My name is Jennifer White. I'm a community member and District 10 resident. Thank you so much for the opportunity to testify on this critical issue of women's reproductive health care. Since 1973, when Roe v. Wade became the law of the land, there have been intentional actions that challenge and restrict safe and accessible abortion care. And over the last decade, we have seen a resurgence of restrictive access, with states seeking to strip away women's liberty and power over their bodies, making it difficult and virtually impossible to seek the health care they need. As Roe v. Wade hangs in the balance, this is an issue about access and protecting Marylanders' rights. To ensure we remove barriers and improve the availability of safe and accessible abortion care, I urge a favorable vote on SB 890, which will increase the number of qualified providers who offer these services. As a public health professional with a passion for women's health, at the very core of safe and accessible abortion care is the availability of qualified providers. The American College of Obstetricians and Gynecologists supports women's access to safe abortion care and recommends to institutionalize training, destigmatize abortion care as a critical aspect of women's reproductive health, and expand the availability of qualified providers. Creating, funding, and sustaining the abortion care clinical training program will yield equitable outcomes for women's reproductive health, expand access and availability to culturally competent providers, and protect access to safe abortion care. According to the Guttmacher Institute, as shared before, we have seen there has been no change in the number of clinics that provide safe abortion care in our state. And in 2017, 71% of Maryland counties had no clinics that provided abortion care, while almost a third of Maryland women lived in those counties. Safe and accessible abortion care is health care. The consequences of restricting access to safe abortion care would be catastrophic, resulting in unsafe abortions and affecting those most vulnerable in our state. We have an opportunity to lead and protect the health and safety of women, and this piece of legislation, SB 890, will increase access to safe abortion care and bring us closer to gender parity over our reproductive health and individual rights. I urge a favorable vote on SB 890 that will establish sustainable funding, access to qualified providers, and protect women's rights. Thank you for your consideration.
Okay, thank you, Ms. White. We'll go next to Lisa Jordan. 2 minutes.
Thank you, Mr. Vice Chair, Madam Chair. My name is Lisa Jordan. I'm with the Maryland Coalition Against Sexual Assault, and we're here supporting Senate Bill 890. Thank you, Chair Kelly, for your passion and your leadership on this issue and for saying many of the things that I would have said, because abortion access is a critical piece of health care for rape survivors and survivors of reproductive coercion. Discussing rape first, the CDC reports that almost 3 million women in the U.S. experienced rape-related pregnancy during their lifetime. A 3-year longitudinal study of rape-related pregnancy in the U.S. found that 5% of rape victims of reproductive age became pregnant as a result of the rape, with the majority of those pregnancies in adolescence. Half of those young women choose to terminate the pregnancy. And keep in mind that adolescents are more likely to become pregnant as a result of rape because they're less likely to already be on birth control or to seek emergency contraception following a rape. And additionally, adolescents are more likely to experience rape, with 32% of all forcible rapes occurring when the victim is between the ages of 11 and 17. Abortion care is also important for survivors of reproductive coercion. Reproductive coercion is a form of intimate partner violence where a woman's partner tries to control reproductive decisions by preventing access to or tampering with birth control, or by forcing sexual intercourse with the intent of causing pregnancy. Survivors of rape and reproductive coercion need access to abortion care if they become pregnant. Let me comment specifically on access to abortion for poor women. As Chair Kelly has already testified, there are currently stigmatizing requirements for Medicaid abortion coverage every year in the annual budget bill. Maryland requires that survivors of sexual assault or incest have filed a police report or a social service agency report to obtain abortion care, when we know that the vast majority of survivors do not make those reports. That is nothing but a naked and significant barrier to care, an attempt to reduce access to care. Maryland's current policies send the unmistakable message that survivors who disclose rape or incest should be viewed with suspicion. Senate Bill 890 will eliminate those disrespectful provisions and replace them with supportive policies that help sexual assault and incest survivors have access to needed health care. And so the Maryland Coalition Against Sexual Assault urges a favorable report on Senate Bill 890.
Okay, thank you. And then finally, our final witness, Rajana, why don't you proceed? You got 2 minutes.
Thank you. Hello, everyone. I am Rajani Goodlove-Aletti. I am Director of Mobilization with Baltimore Harm Reduction Coalition. Baltimore Harm Reduction Coalition is a grassroots advocacy organization that mobilizes community members for the health, dignity, and justice of people targeted by the war on drugs and anti-sex worker policies. As a certified, grassroots, community-based overdose response program, naloxone distributor, and syringe service program, we have provided essential healthcare services across the state for years, which includes case management with folks who trust us and tell us about issues such as needing an abortion, needing reproductive health care, needing a variety of healthcare supports. We meet people in the community where they're at, where they feel comfortable to talk to us. We are not certified to provide abortion care, just to be clear, but we do provide referrals. BHRC strongly supports Senate Bill 890 because it would increase access to essential healthcare services for Maryland's most vulnerable residents, including the clients of our community outreach programs. At BHRC, our work is dedicated to ending overdose and dismantling the systemic issues that undergird our state's rise in overdose numbers. A significant systems issue is the limited access to low-barrier, quality healthcare and compassionate, qualified healthcare providers. Both drug use and abortion are stigmatized. Providers mistreat or even refuse to care for our clients, our loved ones, and even my fellow harm reduction workers. Stigma prevents us from sharing, learning, and listening to anyone, especially Black, Indigenous, and other people of color who've experienced an abortion or used drugs. We need more providers trained to provide abortion care who also respect the autonomy and dignity of people who use drugs and people who rely on Medicare as well. Abortion access is key to bodily autonomy. Autonomy is key to improving the health and safety of our most marginalized loved ones. It ensures everyone has the tools they need to make informed medical decisions about their bodies. Abortion care is a normal medical procedure and must be protected. We ask the Finance Committee give SB 890 and the technical amendment a favorable report. Thank you.
Okay, thank you. Any questions for this panel? Senator Reedy.
And maybe I ask Lisa Jordan. Lisa, I know we've spent a lot of time together in a different committee. I hear everyone on the panel has talked about safe abortion care, and I think abortion care is a very interesting new turn of phrase. But do you agree that we need to be sure, as part of safe abortion care would be making sure that any clinic or medical facility is regularly inspected to be sure that they are providing that safe standard of care?
Thank you, Senator Reedy. It's nice to see you as well. I believe actually that the current regulations that are in place, which do not require that regular inspection, are completely appropriate, and we should not single out reproductive care for special treatment or special inspection.
It is, but abortion care is health care, correct?
Abortion care is health care, and it should be treated as health care and regulated consistently for all types of care and appropriately to whatever level of clinic it is.
So it should be inspected the same way that any sort of physician offering similar services would be inspected?
Well, actually, Senator Reedy, this would not just be for physicians. I think part of the point of this bill is to make sure that advanced care practitioners also have the ability to provide this care. So I would also just say, Senator Reedy, that this is getting a bit outside of my scope of expertise, which, as you know, regards rape, incest, sexual assault, those issues. And so I believe healthcare regulation might be more appropriate as a question for some of the other witnesses, and I'm sure some of them would be happy to provide that information.
May I ask Ms. White a similar question?
That's fine.
Because I think you're more, that's more in probably your scope of work.
I would say that it's outside of my area of expertise,
Okay.
but.
That's okay. I'm not trying to trick anybody. I think it's important we have, if we're calling it, if we're talking about, the previous panel talked about, in my questioning, talked about implementing abortion into every facet of women's health care, every facility. So I think, I just want to try to establish, we should be sure that it's being done safely. So that's my overall, I guess that's the point of my question. So thank you.
Okay.
I would say that the fact that this bill would allow for qualified providers to be trained, that would initiate within itself to allow for abortions to be provided safely and accessibly. So that, again, is the underpinning of this bill that would better allow for women to access abortion care that could be done so safely and accessibly.
Right, so thank you, because I think we just want to be sure, I want to be sure we're regulating it the same way we regulate similar services in the health field. So I know we can talk about that perhaps in committee as we discuss the bill. Thank you.
Any additional questions for this panel? Okay, seeing none, thank you very much for your testimony. We're going to now move to a panel of unfavorables. We've got 4 names: James Walton, Laura Bogley, Kristen Day, and Miss Warham, first initial S. And we will start with, we'll get everybody up here. We'll start with Mr. Walton. James Walton can do the lead off, and then we'll go to Miss Bogley, and then we'll take it from there. And also, since we're being this all out to the world, make sure your mic is close to your, it's sometimes with your masks on, it's a little hard to hear, so make sure you do that. And it's movable, so you can bring it up. There you go.
Can you hear me?
Mr. Walton. Yep.
Okay.
So everybody's got 2 minutes.
Okay. I'm Dr. Jay Walton. I'm the leader of 40 Days for Life in Lutherville. We pray outside of the abortion mill located at 1212 York Road, and we let the scared young women know that God loves them and there are other alternatives to what they're about to do. I'm here today to voice my opposition to Senate Bill 890, also known as the Abortion Care Access Act. I am here today to give a voice to the voiceless preborn boys and girls who will be killed as a result of this bill. I am here to give a voice to the pregnant women who will be hurt, perhaps even killed, as a result of this bill. You called this bill the Abortion Care Access Act. You are being disingenuous to the public by pretending that any level of care is involved in abortion. It seems your goal, your agenda, is to convince mothers that the killing of their babies is not horrific. It is estimated already that nearly 30,000 abortions are performed each year in Maryland. This number will increase should this bill pass. That's not a good thing, by the way. Not a good thing. Abortion is legal through all 9 months of pregnancy in Maryland. Leroy Carhart, the famous, infamous abortionist who will terminate your pregnancy during the 3rd trimester up until the moment of birth. Leroy Carhart himself performed a late-term abortion when Jennifer Morbelli, who was 33 weeks pregnant. The abortionist was successful in killing the child. He was also successful in killing Jennifer Morbelli. Now, despite taking the Hippocratic Oath, Leroy Carhart is an actual physician. Senate Bill 890 will allow people other than physicians to perform abortions. Now, if women are dying from abortions at the hand of a veteran abortionist like Leroy Carhart, it follows then that many women will die from abortions at the hands of what this bill calls qualified providers. This bill will allow nurse practitioners, midwives, and physician assistants to perform abortions. This is both reckless and irresponsible. Please, for the sake of women and children throughout Maryland and those who are going to come to our state to kill their child, withdraw this bill immediately.
Okay, Mr. Walton, we'll go to Ms. Bogley next up. 2 minutes.
Thank you, Madam Chair, members of the committee. I'm Laura Bogley, Director of Legislation for Maryland Right to Life, and I pay people to kill babies. In fact, every taxpayer in this room and watching on video pays people to kill babies through abortion subsidies. Killing our babies does not solve women's problems, and the state needs to do better to provide positive alternatives to abortion. Funding abortion is not by my own choice, but by your vote. Infringing on the constitutional rights you swore an oath of office to defend, including the unalienable right to life and my own right to the free exercise of religion, in this, the original Catholic colony. If it's not my choice, why is it my responsibility to pay for other people's abortions? Because of your votes, Maryland is one of only 4 states that forces taxpayers to fund abortions. We pay abortionists in Maryland $6.5 million each year to kill nearly 10,000 babies. And of those abortions, they were not reported for reasons of rape, incest, and life of the mother. So we don't need that abortion distortion. This is radical policy, as 54% of people who are polled in a January 2020 poll said, whether they're pro-life or pro-choice, say they oppose public funding for abortion. Maryland is radical and out of step with the population. Because of your votes, we are forced to subsidize the $2 billion abortion industry, Planned Parenthood, who in the last 50 years has continued to take our money despite the fact that they have utterly failed in their alleged mission to prevent unplanned pregnancies and make abortion safe, legal, and rare. Maryland women need more care and less abortion. The practice of abortion in America already is the red light district of medicine, populated by dangerous substandard providers, and now by repealing the legal requirement that only a licensed physician may perform abortions, the abortion industry itself is exposing women to back alley style abortions, where they bleed alone without any medical assistance. The veil has finally been torn, and there can no longer be any doubt that abortion is not health care. Abortion is never medically necessary to save the life of a woman. The Maryland Department of Health has failed to ensure that existing abortion providers and facilities are complying with existing Maryland law. Women continue to be injured and killed in Maryland because of ineffective enforcement of existing abortion regulations, the broad expansion of lower-skilled, non-medical abortion providers, non-medical, will create an enforcement nightmare for the Maryland Department of Health. We must protect pregnant women in Maryland and other states by preserving the physician-only requirement for all abortions, both surgical and chemical, and by making it clear that it's not within the scope of independence of...
If you could just bring it a little closer, we're trying to keep everybody to 2 minutes.
Thank you. It's not within the scope of practice of lower-level health workers or non-medical workers to provide abortion. We urge you to get out of the bloody abortion business, starting with your vote against this subsidy. Invest in real solutions for women. It's time. Thank you.
Okay, thank you. And our next witness is Kristen Day, in 2 minutes.
Yes, thank you. My name is Kristen Day, and I am a pro-life Democrat. I represent 21 million pro-life Democrats around the country who oppose abortion and would like to see real alternatives for women facing unplanned pregnancies. I'd first like to address the Texas issue, which came up earlier. And a part of the Texas law, when they passed it, they also provided $100 million for pregnancy support. And the pregnancy support services there saw immediate demand for pregnant women. And there was amazing that the Planned Parenthood, instead of altering their care, they shipped people out of state for abortion instead of providing parenthood support. Second, Dobbs. If Dobbs is overturned, nothing will change in Maryland. Abortion will still be legal. Nothing will change. This bill is unnecessary. Third, when we talk about underserved populations, the underserved populations are the poor, and they are given abortion as their only choice. They're not given support for parenthood, shown that pregnancy centers will support them to carry their children to term. There are barriers in Maryland to carrying a child to term because you pay for abortion with taxpayer funds, and that is the preferred option for an unplanned pregnancy. So I'm deeply concerned about this legislation because of what it will mean for women. This legislation will prop up the abortion industry, giving them more money, which is akin to corporate welfare. I am a Democrat. I oppose corporate welfare, so all my Democrats on this panel should oppose this bill as well, if you support democratic values against corporate welfare. So instead of funneling money to this international corporation, we should put that money, take that $3.5 million and put it toward pregnancy support. Address childcare, high cost of childcare. Address education, allowing women to stay in schools instead of having an abortion. Help them stay in their jobs instead of having an abortion. There's so much more we could do with $3.5 million than paying for more abortions. This legislation endangers the health of women, allowing non-physicians to perform abortion. This is a terrible, terrible precedent to set. And coercing women's bodies to be more like men's bodies by not being pregnant, again, is not powerful to women.
If you could just, summarize and.
Sure, I will be happy to. The violence of abortion has not made women more free. It has not made them equal in the workplace, nor in society as a whole. It is time for better, different direction. It is time to abandon abortion violence and truly advance women's rights and true reproductive freedom that includes support, freedom, and choice to become a parent, even in the face of a crisis or unplanned pregnancy. I urge the committee to table this legislation and focus now on pregnancy support and giving women real choice. Thank you.
Okay, thank you for your testimony. Our final witness on this panel is Ms. Warham. And again, 2 minutes.
Good afternoon. I'm Sheila Warham of Maryland Legislative Lobby for Life, and I have submitted my testimony online. We hold that it's totally inappropriate for a Department of Health, the Department of Health of the state of Maryland, to be having anything to do with training anybody to kill the next generation of Marylanders. Of course, we oppose abortion, but so does, as it was mentioned, the majority of people in this state. They oppose using tax money for abortion, even if they are all right with other people using their own money for abortion. But the idea that our state would train people for a private industry, which is what the abortion industry is, and one that kills the next generation of Marylanders, is very inappropriate. Regarding the bill's coordinating organization, it's tailor-made for Planned Parenthood, which already has a history of I have the citations of which lines in the bills this all goes to. It has a history of training doctors already for decades now. It has the coordinating organization needs to pick 2 sites to train. Planned Parenthood has 2 abortion clinics in Baltimore and Annapolis where they could train and staff their own clinics. And in addition, Planned Parenthood is a very controversial organization because they locate their clinics in minority areas. They abort the children of minority girls and women. And many of those girls and women have learned about Planned Parenthood in their high school classrooms, because when I was invited in to give the pro-life balance in these public school classrooms, Planned Parenthood was saying, your mother will never find out about it. And this bill completely destroys parental notification. Parental notification was on its deathbed anyway. It's written in there with every kind of exception you could ever want, and this bill says that all you need to do for parental notification in the girl's chart is put a notice that you attempted it. Mrs. Smith, oh, she never answered. So these practices take advantage of the young, and they're looked upon some as genocide, and I have a note in my testimony. But who are these trainees? The
Ms.
bill
Ms.
says.
Warren, since we do have your testimony, if you could maybe,
I am, yeah, I will,
summarize. We
yeah.
do have your written testimony.
But this is very important, I think. Who is, so in addition to the named, midwives and physician assistants, et cetera, the bill says that it applies to any other individual who is licensed, certified, or authorized to practice in the state. Well, opticians, nursing assistants, nutrition specialists are all certified to practice in the state. This bill makes no distinction as to who is going to be trained by this $3.5 million. And it says something about performance of abortion being within the scope of the individual's license. Not one of the people named has abortion within the scope of their license except the physicians. So it's meaningless. And does anyone think that this will be sufficient training? The Attorney General gave an opinion in 2020 that abortion can only be done by physicians, and the reason why is that none of the people named have the surgical training necessary to handle lacerations of the cervix, perforations of the uterus, and hemorrhaging. And as I said, you need more than the ability to call 911 if...
Okay, thank you for your testimony. Any questions for any of the panelists? Okay, thank you so much for your testimony today. Appreciate that. And we're going to go now back to a panel of favorables. We've got Adriana Harvey, Mary Shorey, Lynn Cow, and Mahima Krishnamoorthy. And so we'll go in that order, and we'll have people testify in that order, starting with Ms. Harvey, leading off. And we're missing 2 people. Let's get all 4 people up to stand.
Hello.
Okay. Everybody's got 2 minutes like the last panel. Okay? Thank you.
Hello, my name is Adriana Harvey. Thank you for having me. I'm a medical assistant at an abortion clinic in Baltimore City. I would like to read an experience from one of my colleagues whom is
Yeah, why don't you, we're having a little difficulty. Pull that mic up close. You can pull it up there, get through the mask. Okay, go on.
I would like to read an experience from one of my colleagues whom is a practice clinician. The reason I'm reading this and not my colleague is due to atmosphere around abortion care. Abortion is health care, but people who provide abortion are victims of harassment, threats, and worse. I hope this bill is the first step toward a world where that is no longer true. Here's my colleague's story. Here's just one example from just the other day in my office. I had a patient who was a single mother of 2. She drove over an hour to get to an office for a medication abortion. She told us that she had a long history of anemia during her medical history, and sure enough, her hemoglobin was low. She was constantly dry heaving from pregnancy, nausea, and looked exhausted, though she was very early in pregnancy. With her low hemoglobin, she needed an in-office procedural abortion so her bleeding could be safely managed. This news was devastating to her. Getting herself to Baltimore, which is much farther away from the office that the clinician was in, for any appointment as a single working mother was nearly impossible. Taking another day off from work because of pregnancy nausea or another appointment was going to impact her family financially. She proceeded to take iron supplements, nausea medication, and return into our office every few days for a hemoglobin check. After 2 weeks and 4 visits to our office, she finally had a hemoglobin level sufficient enough to proceed with the medication abortion. If I had been able to, and this is speaking from the clinician, if I had been able to do an in-office procedure for her on that very first visit, I could have saved her 4 additional appointments, 2 weeks of extra medications and pregnancy side effects, and multiple paychecks. This mother sacrificed so much for her 2 daughters in having an abortion, and I could have made that process easier if you removed the physician-only clause associated with abortion care. Thank you for the opportunity to share my colleague's story.
Okay, thank you, Ms. Harvey. We're going to go next to Ms. Shorey.
Good afternoon. My name is Dr. Mary Shorey, and I'm an OBGYN physician who provides full-spectrum reproductive health care. I'm also a fellow of American College of Obstetrics and Gynecology, or ACOG, and I'm here today on behalf of ACOG's Maryland section to express strong support for Senate Bill number 890. This bill establishes abortion training programs that empower advanced practice clinicians to provide medication and procedural abortion care. This will increase access to safe, effective abortion for those who need it. At the abortion clinic where I work, A nurse practitioner is available daily to counsel patients on available and safe abortion care. Due to other staffing needs, a physician can only be present twice a week. This means that patients often need 2 visits at least to obtain their abortion, a counseling visit with a nurse practitioner and a procedural or medication visit with a physician. With appropriate training as outlined in this bill, this nurse practitioner could easily facilitate most of these abortions independently and reduce the burden on patients. This is especially important because approximately 70% of Maryland counties have no clinicians that provide abortion, as you've already heard, meaning many Maryland women travel far from home already for their care. I have seen how this particularly affects my most vulnerable patients, those who struggle to take time off of work, find transportation, navigate language barriers, or find childcare to make that trip. I took care of a patient this week who had delayed her abortion until she could secure and afford childcare for the time it required to take 3 buses to our office and back for her appointment. I cannot imagine asking her to delay further and make that trip twice. Strong evidence has shown that the safety and efficacy of abortion care provided by advanced practice clinicians is equivalent to that provided by physicians. Physician-only laws only exacerbate inequalities in access to this essential health care. We as a community are obligated to remove these unjustified and unscientific barriers to evidence-based abortion care and to pass Senate Bill 890. Thank you.
Okay, Doctor, we'll go next. We're going to go to Ms. Cow, and again, 2 minutes.
Hi, good afternoon, everyone. My name is Lynn Cow, and I'm a medical student in my 2nd year at Johns Hopkins School of Medicine. I hail from New Jersey, but the reason I currently take residence in Maryland is to work towards my aspirations of providing gynecologic and reproductive health to my future patients, be it through a specialty in obstetrics or in gynecology or family medicine. My colleague and I come to you today to tell you why we believe the Abortion Care Access Act will not just fulfill our goals of caring for our future patients, but will serve the health of Maryland's people. One way the Act does so is by expanding abortion training programs to fill in the many gaps left by medical education. As it stands today, there's no standardized formal abortion training in our clinical curriculum. I've spoken to peers who vary in their response regarding their exposure to medical and surgical abortions in their OB-GYN clinical rotation, with some shadowing a few abortions by chance and others never being able to. Some medical students in Maryland rotate through hospitals that do not provide abortions at all. The chance to observe and practice abortions in a professional setting are only available to those who opt into the family planning elective, which can be 2 to 4 weeks long and only available to a select few students. The Johns Hopkins Chapter of Medical Students for Choice, a student group that we lead, hosts a yearly workshop to address the paucity of procedural abortion training. This event is led by an OB-GYN attending and fellows specialized in family planning and focuses on providing a very basic understanding of abortion care. The event always draws a large crowd, including those not directly interested in the OB-GYN specialty. There's clearly significant interest in learning how to perform abortions, but workshops such as ours can only provide an introductory level training. The burden should not be on students to organize training, but rather should be integrated into formal training programs that are broadly accessible. I want to emphasize that the training issues I'm discussing are happening right now here in Maryland. Access to training nationwide is likely going to be significantly reduced following the Supreme Court's ruling in Dobbs. Passing this bill will ensure that Maryland will have a fully diverse workforce of trained providers that are competent and know how to deliver safe and effective care. Thank you for taking the time to listen to and giving me the opportunity to tell my story. I will now hand the floor to my colleague.
Okay, thank you, Ms. Cowell. Next, final witness on the panel. Go on, proceed.
Good afternoon, everyone. My name is Mahima Krishnamoorthy, and I'm a first-year medical student at Johns Hopkins School of Medicine and co-president of our chapter for Med Students for Choice. I grew up in the Central Valley of California, often helping my parents in their rural health clinic and seeing the role they played in addressing health disparities. There, I developed a passion for reproductive health and justice. As an undergraduate at Stanford, I wrote my thesis on the experiences of women who have had abortions. But when I came to Hopkins, I was elated to be expanding on these passions in one of the best hospital systems in the world, in a state rich in history and diversity. But I quickly understood the reality that Lynn has discussed, the paucity of formally supported training programs in Maryland for abortion, a health procedure more common than many other medical procedures we learn about in standard medical school courses. I was not surprised, though, that the health disparities that I saw growing up in rural California are endemic to Maryland as well. Black and Hispanic residents are still disproportionately affected by limited insurance coverage of abortion, and rural Marylanders face limited access to reproductive health care.
Simply put, the state desperately needs more abortion providers, especially in areas with limited access to existing resources. It is no surprise that the state experiences a dearth of abortion providers, especially when those that do practice face harassment and threats in their daily lives. We need more trained medical students, mid-level providers, and midwives to create a capable and sustainable reproductive health system. This bill is not about creating new jobs, but rather empowering already working medical providers to expand needed healthcare in their communities. And given that evidence has shown time and time again that abortions are safer than colonoscopies, dental procedures, tonsillectomies, and most importantly, childbirth, mid-level providers are more than capable of providing that care. Medical students would be lucky to train in abortion healthcare in medically underserved areas, but we cannot do that until there are more providers that can train us. In just my first year as a medical student, I've already met people like Jane and Bob, parents to 2 boys who were not financially ready for a third. I've met women like Anna, Maria, Linda, people for a whole host of reasons, emotional, health, financial, are not equipped or prepared to have a child. Whether you know it or not, everyone in this room knows and loves someone who has had an abortion. And more importantly, we all know someone who has yet but will seek out an abortion. So for our future patients, for all of the Annas, Bobs, and Marys, the Abortion Care Access Act ensures that there are enough trained providers in this state to care for them and guard their reproductive health. Lynn and I, as 2 members of the future of medical practice in this state, stand in firm support of this bill.
Okay, thank you for your testimony. Any questions from anybody for this panel? Okay, seeing none, thank you. We're going to go now to panel of unfavorables. Hannah Wolf, Francis Arlinghaus, Maria Hayden, and John Quinn. And we'll start with Ms. Wolf, and then we'll go down the panel.
Good afternoon. My name is Hannah Wolf. I'm here today as a representative of Students for Life Action in opposition of Senate Bill 890. Students for Life Action and Students for Life of America are grassroots organizations present in all 50 states and on more than 1,300 middle school, high school, college, and university, and medical and law school campuses. We exist on 29 campuses here in Maryland, and I stand here also as a representative of the pro-life generation here in our great state. I'm here in opposition of the Abortion Care Access Act. One of the few protections for abortion-seeking women in Maryland is the requirement that abortions be carried out by a licensed physician. This bill's expansion of who can carry out already deadly and dangerous abortion procedures places women at even greater risk of harm than they already face when walking through the doors of an abortion facility. There are no maternal health benefits associated with subjecting women to an expanded pool of abortionists. There are only risks. The lack of protection only serves to create a higher profit margin for the abortion industry. This bill cannot be passed in good conscience where the profit of a few is placed in higher regard than the lives of children and the health and safety of women in Maryland. Senate Bill 890 would also massively expand the reach of chemical abortion pills in our state. Chemical abortion, also referred to as medication or medical abortion, is comprised of 2 drugs called mifepristone and misoprostol. The first pill is designed to starve the child to death. The second pill, misoprostol, is designed to induce labor and is taken by the woman at home. Not only can this massively increase the risk factor to women who may have an adverse complication, such as hemorrhaging, but can also be extremely traumatic. This do-it-yourself abortion is intended for women to essentially carry out abortion on themselves, potentially seeing their stillborn child in the toilet following the induced labor process brought on by the second pill. As a woman who has myself experienced an at-home miscarriage where I saw my own child in the toilet in front of me, I can tell you that this type of abortion is anything but health care. To this day, I experience flashbacks and nightmares from the horrifying moments of seeing this tiny person, my own baby, lifeless in the toilet. Stories of women traumatized by what they saw while undergoing a chemical abortion are already piling up. Expanding those who are able to distribute these pills in Maryland will subject more women to this traumatic and psychologically damaging experience. I implore you to see the implications of what this means for our state and oppose the Abortion Care Access Act. Thank you for your time and ability to speak to you today.
Okay, thank you, Ms. Wolf. Well, we'll just go down and just state your name for the record.
My name is Dr. Frank Arlinghaus. I'm from Ellicott City, Maryland.
I'm joined in opposition to this bill by my wife and 3 daughters, one of whom is an emergency department nurse who has worked in both DC and Maryland and has experienced some of the things that, that Hannah just spoke to. Very quickly, you have my written testimony. $3.5 million for training for a profitable industry is not appropriate. The bill is open-ended. Funding this in perpetuity without specific goals is problematic. We're experiencing greater healthcare shortages, including a critical shortage of nurses right now. Most abortions are routine, but complications of either medical or chemical abortions require properly trained physicians. A woman's life may depend on it. Parental notification right now is overridden by an abortionist who has a financial interest and will also prevent effective measures of success or abortion tourism. Maryland's deliberate lack of record keeping means we don't know how many abortions are done on minors without parental notifications, nor do we know that any abortion provider has ever turned a minor down or actually required parental notification. This bill also forces insurance providers to cover abortion without a deductible or copayment. This discourages the marketplace. It introduces a hidden tax levied against a subset of the taxpayers. It also prevents people like myself from being able to buy an insurance policy that is consistent with my individual conscience, which doesn't permit me to fund abortion. And yet, as Laura Bogley pointed out, every taxpayer in Maryland is already paying for 10,000 abortions a year in aggregate. So this limits our individual conscious rights. But that's even more horrifying when you realize that we are funding late-term, third trimester abortions in the state of Maryland. A recent Marist poll shows that most Americans are against not only third trimester abortions, but second trimester abortions, all of which are funded under this plan. Already the abortion clinic in Bethesda that advertises third trimester elective abortions done up to 35 weeks has been granted. I will end by saying my daughter has experience in the emergency room at Children's National Hospital of having seen some of the issues that occur post-chemical abortion on minors. And girls are just dropped off at the hospital and dumped on the emergency room doctors. Fortunately, those emergency doctors are very skilled, but I'd like to see us make sure that girls and women have access to physicians when they're undergoing these horrific procedures. Thank you.
Okay, thank you. Okay, we'll go to Ms. Hayden, then we'll finally Mr. Quinn. Ms. Hayden?
Hello, I'm Maria Hayden. I'm a vascular access board certified registered nurse. I oppose Senate Bill 890 because allowing non-physicians to perform abortions demeans and imperils women. Abortions are already risky. Severe injury and death, as we've heard, can occur from hemorrhaging and infection. 1 in 50 surgical abortions require additional surgery to manage the complications. Many Maryland abortions are beyond first trimester, so this increases the risk. There are multiple medical boards that recommend that in addition to the normal 12 years of training, doctors should get an additional 2-year subspecialty to do abortions past the first trimester. But instead of increasing safety, this bill trivializes abortion by proposing that any licensed person with altered training can perform a high-risk procedure. They'd be working in substandard rural clinics far from hospitals with no admitting privileges. As a nurse, I know that advancing the care we provide, even if it's within our scope of practice, is a serious matter. It carries with it enormous responsibility and liability, and it's not done without grave reason. Abortion itself is never an emergency because there's no disease to treat. Women are not harmed by waiting or by traveling to an accredited doctor and facility. Reducing standards for practitioners is an unnecessary and an unacceptable risk. But this bill is proposed because the number of abortionists is dwindling, and it would ensure revenue for the abortion industry. Mainstream doctors don't want to do them. Only the dregs of the medical profession become abortionists. It's a dirty, gruesome, bloody business. And it doesn't heal anyone. This bill prevents release of the names of the providers, not an upstanding industry if it has to hide its practitioners. Allowing non-physicians to do abortions defies logic for those who say they care about women. It clearly tells women of Maryland that their health can be sacrificed for profit. Thank you.
Okay, Ms. Hayden, and Mr. Quinn, 2 minutes.
Thank you, Madam Chair and Mr. Vice Chair. My name is John Quinn. I serve as the Business Operations Assistant with the DFLA Education Fund. As a resident of Maryland and a proud pro-life Democrat, I oppose Senate Bill 890. As a Democrat, I value nonviolence and equality. This legislation advances neither of those values. Without for a second denying the various financial, social, emotional, mental, and physical challenges of pregnancy, childbirth, and parenthood, we can and must question if abortion is a dignified and effective response to those challenges. Abortion deliberately ends the life of a preborn child, and so abortion is properly understood as violence. Our system of government rightfully prohibits violence against our fellow human beings. Instead of diminishing the violence of abortion, this bill would augment it, and so must be opposed. And I'd like to point out the proponents of this bill have held up the state of Maine as an example for having more abortionists in more counties than Maryland. But if you look and compare the abortion rates between the two states, Maine's abortion rate is half that of Maryland's. So I would agree with those who are championing this bill. We should find ways to be more like Maine and lower our abortion rate. Furthermore, the violence of abortion fails to advance the equality of women in our society. If this legislation is passed, more preborn girls will lose their lives to abortion violence. Crucially, the aforementioned challenges that lead women to consider abortion will be left unaddressed. For example, the Maryland Department of Health currently prohibits grants to pregnancy centers which do not provide abortion, but do provide pregnancy tests, ultrasounds, and other care and resources to mothers. The state of Maryland clearly communicates to its citizens that it will support them in terminating pregnancies, but will not lift a finger if they want to carry their child to term. Our societal system pushes women into abortion rather than providing robust investment in those women and their families. As this legislation furthers that harmful trend, I ask the committee to table it.
Okay.
Thank you very much.
Okay, thank you, Mr. Quinn. We've got a question from Senator Bidle.
Thank you, Mr. Vice Chair. I think this is for Ms. Hayden, because you talked a lot about the results of abortion, but I'd like to know, do you ever see patients that have tried home abortions?
I don't personally, that's not my field.
Okay.
As I said, I'm a vascular
Because that's my
access nurse.
concern. And while you were talking, I Googled home abortions. It's amazing, amazing the number of sites that come up to teach women how to do their own abortions, both chemical abortions and other ways to do home abortions. And so that's my concern, that if we aren't providing safe medical care for women, they're going to do it themselves. So I'm sorry you can't
But
answer the
safe,
question.
the safe is not defined by having someone who's never done it before. If I had to travel to have open heart surgery, I would do that 6 hours rather than have someone down the street do it who doesn't know how.
Okay, I think any additional questions for anybody on the panel? Okay, seeing none. We've got two final favorable witnesses and then one unfavorable left. So the two favorable on the list here is Scott Tiffin and Frank Patinella. So if you two could come up, and then we'll then turn to Pamela Palumbo, signed up unfavorable. She'll be on the next panel. So, sir, you're Scott Tiffin, or are you Frank?
I'm Scott.
Okay, Scott. I'm not sure Frank is here.
No worries.
Okay, Scott Tiffin,
Yep.
2 minutes.
Thank you, Madam Chair, members of the committee. My name is Scott Tiffin, and I'm here with the Maryland affiliate of the American College of Nurse Midwives. Many other folks have gone before me already and given much better testimony than I probably could, but I just wanted to touch on maybe two issues. One is that in preparing for this bill, I talked to a lot of providers across the state of Maryland and actually across the country. And two of the things, we heard about a lot of barriers to care, but two of the things that kept popping up and talking to folks all over was one is harassment of providers and pushing providers from not wanting to provide care that they otherwise would really want to provide and that they know is important to their patients. The other big universal thing we heard was a lack of training. You know, whether it's med students or NP students or even fully licensed providers, just not having the ability to get the training that they need in order to provide competent abortion care. And so there's a real fear amongst these folks I've talked to about what's going to happen after the Supreme Court rules in Dobbs, and just not being able to get any type of training in huge portions of the state or portions of the country. And what that will do to Marylanders. You know, we have plenty of doctors here in the state of Maryland who did all of their training in a state that restricts abortion. You know, we may be completely cutting them off from any sort of training for when they come here to Maryland and greatly reducing the workforce that we have here in the state. Thank you very much, and I'm happy to answer any questions.
Okay, any questions for Mr. Tiffin? Okay, thank you.
Thank you.
Seeing none, we're going to go to our final witness on this hearing, unfavorable, Pamela Palumbo. Ms. Palumbo? Okay, go on.
Good afternoon. Thank you. My name is Pamela Palumbo, and I serve as the president of the Maryland Coalition of Medical Pregnancy Clinics, which represent 30 medical clinics across our state, caring for more than 20,000 women a year with totally free services, including in Hagerstown. I deeply respect our medical providers with nurse practitioners and others on my staff. However, this legislation is looking to overturn why, for a very good reason, an MD's scope of practice is larger and more complicated. In my written testimony, I note 4 of the most recent cases of appalling abortion injuries to women by abortions performed by nurse practitioners who were trained in Maryland. MedStar Washington Hospital Center employee Pam Loti reported the injuries and said, quote, "While I understand that complication happens in any procedures, the severity and frequency of these complications is disturbing. This has prompted me to reach out to the Department of Health. By report, the patients have only mentioned nurse practitioners in their care, no physicians. This bill has also had a detrimental effect for minors as it further erodes the already weak parental notification, and parents will have no idea why their 13-year-old is hemorrhaging and distressed from a surgical or medical abortion. I can speak firsthand to the explosion of unregulated medical abortions by pill, sold and handed over the counter or by mail. The number of teens and women calling us for abortion pill reversal continues to skyrocket. When women realize they were sold a medical abortion, they'd never had time to consider and then change their mind. This bill wants to fund and increase this out of the pockets of all Marylanders. Maryland Planned Parenthood charges the exact same $390 for a first trimester as they do 2 pills for a medical abortion that a woman performs herself. Those of you who understand business and a return on investment can clearly see the vast increase in profitability. Abortionists also then submit that $390 to Maryland Medicaid for reimbursement, regardless if it's medical or surgical. At the intersection where abortion and profits meet, they are asking you, our legislators, to be complicit with them by opening Pandora's box of lowering standards of care and patient service safety for women over the profits for the abortion industry. I strongly urge you to protect Maryland women by preserving the physician-only requirement, and please vote unfavorably against Senate Bill 890.
Okay, thank you, Ms. Palumbo. Any questions for the witness? Okay, seeing none, Madam Chair, that concludes the hearing on Senate Bill 890.
Thank you. Okay. We're going next to Senate Bill 787, Managed Care Organizations and Health Insurance Carriers Prior Organization for HIV Prophylaxis for Victims of Sexual Offenses Prohibition. We're going to call up, okay, and let's call up your panel.
Yes, I've got a panel of Lisa
Dana
Jordan
Kaufman and
and
Lisa
Dana,
Jordan.
I think Dana Kaufman and Lisa Jordan. Okay, Madam Chair, let's maybe get everybody out of the room here. Okay. Madam Chair, this is a very narrow, specific bill. I don't believe there's any opposition. So prior to session, I was part of a meeting with MedCai and our Montgomery County Medical Society, and a physician reported that one of her patients, a sexual assault survivor, was denied immediate access to a post-exposure prophylaxis medication, PEP, that's used to prevent HIV if given immediately after an alleged rape or sexual assault due to the obstacle of a pre-authorization requirement from that patient's insurance carrier. After learning this, we did a survey of Maryland's carriers and conducted, and became clear that most carriers do not, I repeat, do not have pre-authorization requirements for PEP given. However, the practice not prohibited, and unfortunately, at least one Medicaid managed care organization apparently has a pre-authorization requirement for these HIV prevention drugs that need to be given immediately after an alleged rape or sexual assault. So again, PEP is used to prevent HIV infection after a person's been exposed to the virus. In order for it to be effective, the medication must be taken within 72 hours of exposure. Otherwise, the research shows the medication has little or no effect on preventing HIV. The faster it's taken, the lower the chance of infection. So, Madam Chair, it goes without saying that a prior authorization requirement can delay or even deny administration, but can only be described as a life-altering or life-saving medication. So all Senate Bill 787 does is it removes this barrier. It prohibits prior authorization requirements for HIV post-exposure prophylaxis medications, PEP. There is an amendment. As originally drafted, the prohibition on pre-authorization would only have applied to victims of sexual assault. After discussions with the stakeholders, doctors, insurance carriers, I have an amendment in order to ensure the patient privacy that we're dealing with here, and we're altering the language from victims of sexual offense to for use in accordance with Centers for Disease Control and Prevention guidelines. So it's not limited to just, again, in the aftermath of a sexual offense. So again, that one amendment, Madam Chair, I'd ask for a favorable on 787.
Thank you. Are there any questions? Okay, don't see any, so we'll go to your panel. Let's start with Dana.
Thank you very much, Chair Kelly, members of the committee. For the record, my name is Dana Kaufman. I'm here today on behalf of MedCai. Senator Feldman pretty much laid it out for you. We think that this is an extremely important bill, given the fact that prior auth can delay treatment, and in this situation, treatment cannot be delayed if you want to successfully be able to reduce the risk of infection. So with that, I would urge a favorable vote. Thank you.
Thank you. No questions? Okay, Lisa Jordan.
Thank you, Madam Chair, Mr. Vice Chair, members of the committee. I'm Lisa Jordan with the Maryland Coalition Against Sexual Assault. We're here supporting Senate Bill 787 with the amendments described by Senator Feldman. Senator Feldman, thank you for your leadership. You know, this really is kind of a straightforward bill. The one thing I will just add is that there's currently a program in Maryland. Senator King has a bill to remove a sunset on it, but it would have provided this woman with NPEP for free. It was that she chose to use her health insurance and really reduce the burden on the state that led to a situation where she couldn't get the medication at all. Really a very absurd result in this case. Hugely important for rape survivors, but also for any of us who have, you know, the misfortune to be exposed to HIV. So I'm happy to answer questions, but again, very straightforward, but super important bill, and we urge a favorable report on Senate Bill 787.
Okay, sponsor has a bill.
Council just brought to my attention that there's a bill over in EHE, Senate Bill 355, Senator Lamb, that may include some of it. I just want to make sure that we're having a hearing that's not sort of moot by virtue of some other bill over in EHE. So do you know what I'm talking about?
I am familiar with that bill. I'm not sure that they conflict or not. Okay. But I do know that that bill is primarily dealing with whether pharmacists can distribute both NPEP and NPrep, which is before exposure. Ms. Kaufman may have more information.
We can take a closer look at that just to make sure that they are consistent with each other and they're not duplicative, and get back to
Okay, because
Mr.
in
Carlson.
fact, there's Senator Lamb, ironically, on a different bill, but I think it's on the EHE voting list tomorrow, a Lamb bill. We were just invoking you. Okay, so we'll look into that, Madam Chair. I just want to put that out there.
I would note, Mr. Vice Chair, that there is no cross-file on the Senate Bill 355, and this bill is on the voting list in HGO on Friday, so would not want to see this bill fail unless the other bill was actually
Okay,
successful.
we'll figure it out. Okay, thank you.
Okay. And then Pam Casemeyer, favorable with amendment.
She's not here. That was in case I had to run.
Okay. I believe in being prepared. All right, then that ends the testimony on this bill.
Thank you. Thank you.
Okay. Senator Lamb, he's here on Senate Bill 734, Health and Health Insurance Primary Care Reform Commission. And let's see, let me bring up your first couple of witnesses.
I think we have Dr. Haft.
Haft here.
Yep.
Okay. And Pam Casemeyer and Suzanne Schlockman.
I think Ms. Casemeyer may be out in the lobby, but she'll probably come in any second now, and as well as Ms. Schlockman. So happy to be here, Madam Chair, members of the Finance Committee. For the record, Clarence Lamb, Senator in District 12. Senate Bill 734 is an effort to establish a healthcare work group here in the state of Maryland to review, examine, and make certain determinations and recommendations regarding primary care spending here in the state. The bill, as originally drafted, sought to establish an independent commission. However, in conversations with stakeholders, we are introducing this bill with a sponsor amendment that will task a work group within the Maryland Healthcare Commission to accomplish the same intent as the original draft of the bill. An additional amendment is also in drafting, will be submitted to the committee to ensure that language pertaining to analysis of the considerations of equity, as well as demographic disparities in health care outcomes and ways to reduce barriers to assessing primary care services that were in the original draft are also retained in this amended version. And that amendment should be to you shortly. The work group that SB 734 establishes will include representatives from the Office of the Maryland Primary Care Program, the Health Services Cost Review Commission, and the Maryland Insurance Administration, representatives within the primary care community, and health services researchers with expertise in primary care. I've provided in my written testimony the larger amendment as well as the interlineated copy that incorporates these changes. Would like to thank MedCai and the Department of Health for collaborating on this effort, as well as the Maryland Healthcare Commission for offering to facilitate this work group. As this committee is aware, the importance of primary care to the health of a population cannot be overstated. Primary care is often the first contact for a patient in the healthcare system and is built on a long-term trusted relationship between a patient and provider that is not always common with other healthcare providers. Primary care providers help a patient with managing chronic diseases and preventing future illnesses. And as you've experienced, primary care providers coordinate the care of complex medical conditions with specialized physicians. They also serve to help improve access for patients with mental health issues, which, as we have seen over the last few years, has become more prevalent throughout our communities. You will see in my written testimony a variety of resources that affirm the effectiveness of primary care services and the benefits related to establishing this work group. The written testimony goes into more detail, but I'd like to just highlight a few points. Research has affirmed that communities with a greater supply of primary care services are associated with better public health and more equitable health outcomes. For example, one study that I cited in the written testimony found that an increase in 10 primary care providers per 100,000 people is associated with a 51-day increase in life expectancy in that population. Nationally, the United States spends about 5 to 7% of its total healthcare spending on primary care. However, in Maryland, we underspent this national average at about 4.6% on these services in 2018, according to the Maryland Healthcare Commission. As our population continues to grow in age, a study in 2010 was conducted to analyze how many primary care physicians would be needed to maintain our current utilization of primary care services. This study found that the state would need to recruit more than 1,000 new primary care physicians by 2030 to establish a healthcare environment that can effectively serve our population. That represents a 23% increase in our current primary care workforce. Many of you are aware that the shortage of our primary care workforce are facing are both through both the anecdotal experiences that have been brought forward to this committee as well as through data that's been highlighted in prior witnesses to other bills as well. And we've also brought forward numerous telehealth bills, among others, that helped introduce and expand authorizations to care for and address access issues. Senate Bill 734 aims to help address these issues by forming this work group that can deliberately focus on policy solutions to promote a more accessible primary care environment. As amended, this work group will have the purview, authority, and expertise to make recommendations to the General Assembly as well as to the Governor's office. These recommendations can include physician reimbursement reform, medical school student debt relief, and increased funding for primary care graduate education. These and others are all important issues that need to be addressed if we as a state are going to keep moving forward with addressing primary care needs of our residents. Maryland is not the only state that has identified this need to coordinate and improve access to primary care. 10 other states have or are enacting similar legislation on this important topic with many of the same goals that I've outlined here. So in closing, this bill will make recommendations to the governor as well as the General Assembly in creating recommendations to ensure that Maryland has a strong, effective, and resilient primary care workforce capable of keeping our residents safe and healthy while also reducing healthcare disparities. I would like to thank and acknowledge the Healthcare Commission for their willingness to work with us on amending this bill, as well as my sponsor panelists who are here to testify today, and also like to thank the committee for consideration of this and urge a favorable report. Thank you.
Okay. Let me ask you one question, Mr. Sponsor.
Sure.
The bill is not without some opposition, and I assume, just given the source, that it's probably got to do with financing. Is this going to be very costly? Have you reduced it all by changing the bill and amending it, what it would cost to implement?
Yes, we have. So I think there was some concern early on with the composition, and we're open to thoughts on composition as well. I think a lot of stakeholders that want to be involved in this and want to have a voice in some of the considerations and recommendations that come forward. The cost as well should come down because a lot of this is now being facilitated by the Maryland Healthcare Commission, and that's why we appreciate their support and willingness to be able to come together with us on this, and that should help reduce some of the costs and need for a separate commission as well. So this can essentially be done as work under the existing Healthcare Commission.
I see. Okay, thank you. What did you just let us in? Senator Augustine.
Thank you, Madam Chair. Mr. Sponsor, you just mentioned help dealing with disparities. I'm not seeing it in the bill. Is it in there?
So it was in the original version of the bill. We also made some amendments to the bill to update it to what we were saying with having the Healthcare Commission address some of these findings and to help facilitate the work group. During that drafting process, some of the issues that pertain to disparities were left out, and that's what we want to retain. So there's another subsequent amendment that's coming that will help retain some of the language that's in the original version that you're seeing that helps address some of the disparity issues.
Okay, I'll look forward to seeing
it. It was an accident that was removed, excised as part of the amendment.
Okay, thank you. All right, we'll go next to Howard Haft. You have 2 minutes each.
Thank you, Chair. Chair Kelly, Vice Chair Feldman, and esteemed committee members. I'm Dr. Howard Haft, speaking in support of SB 734 as amended and with the additional amendments that Senator Lamb mentioned. And I'm speaking as an independent physician with 48 years of experience in the delivery of primary health care, so with some expertise in that area. Primary care is the front door and the foundation of the healthcare delivery system. And in many ways right now, that front door and foundation is in serious trouble. Often overlooked is the fact that 40% of all care for all of us is delivered by primary care providers. However, in the course of our deliberations heretofore, no true and accurate measure has been made of the amount of the total healthcare dollars that are spent that go to the support of that primary care healthcare, or the amount that is even needed to provide essential primary care services. What we do know is that the trends are decreasing, both in the numbers of primary care providers, those that are needed, and the investments in primary care. The work of primary care is built on this long-term trusted relationship. It includes prevention, in order to avoid serious, even life-threatening diseases. And the management of this, what we're facing now, which is a tsunami of chronic diseases, it's overwhelming all of us, this state, this nation, and a good portion of the globe, things like diabetes and hypertension and heart disease and obesity. And it is the work of primary care to deal with those conditions. And if not dealt with, the consequences are dire. In order to meet the current needs of Marylanders, primary care has begun in a small way to begin a dramatic transformation from the time when we provided care one at a time to people to team-based care. And team-based care accepting the needs of a population that's being served. And this speaks to the issues of equity and disparities. But all of that takes a different kind of funding and a different kind of investment than we're used to in the past. The recent National Academies of Science, Engineering, and Medicine report, which was entitled Implementing High-Quality Primary Care, Rebuilding the Foundation of Healthcare, which was issued late in 2021, noted that high-quality primary care is the foundation of a high-functioning healthcare system and is critical for achieving healthcare's quadruple aim, which is enhancing the patient's experience of care, improving the health of the population, reducing costs, and I'll emphasize that, reducing costs, and improving the healthcare team experience. Primary care, as Senator Lamb mentioned, is the only healthcare component where an increased supply of that healthcare component is associated with better population health, more longevity, less death, and more equitable outcomes. So the source of all equity in healthcare really devolves from primary care.
Dr. Harvey, about a full minute over, if you could wrap up.
I'll finish quickly. So even this, despite the critical need for primary care, studies have shown that there's an overall decline in primary care providers. Many of you may have felt that effect as you find it's harder to find a primary care provider and waiting times for visits become longer and longer. Senate Bill 734, Primary Care Reform Bill, will finally accurately quantify the primary care spending in Maryland and make recommendations to the Governor and General Assembly on creating targets for that spending. Will ensure that Maryland has a strong, effective, resilient primary care workforce capable of keeping Marylanders safe and healthy. And the other states that are involved in this now currently, either with legislation or legislation and regulation in process, include Delaware, Rhode Island, Maine, Connecticut, New York, Massachusetts, New Jersey, Oregon, Washington, Nebraska,
We're going
Idaho,
to have you bring it.
et cetera. So I seek a favorable vote on this very important piece of legislation.
Okay,
Thank you very much.
I do want to ask you one question. You mentioned team-based care. Is that a modality within this bill or in its amended form to cut down on costs or to be able to use available personnel more efficiently?
Yeah, absolutely. So primary care now, as it's currently configured, the high-quality, high-value primary care is team-based care. It includes care that includes not only a physician, their medical assistants, nurse practitioners, community health workers, psychologists, LCSWs, all working together in the same unit and going outside of the four walls of the office and dealing with issues that exist in the community, and doing that in a very data-driven way to address disparities and to achieve equity. So that really is where we're driving. That's where we've begun in a very significant way in Maryland, and where this bill will help us mature that.
Okay, I was wondering beyond that.
Good primary care is team-based care. So I think you bring up a very good point.
Okay, all right, thank you. All right, well, we're going next to Pam Casemeyer. She's representing MedCai and a group of other organizations.
Yes, Madam Chair, members of the committee, Pam Casemeyer, and as noted here on behalf of MedCai, but probably as or more importantly on behalf of the Academy of Pediatrics, the Mid-Atlantic Association of Community Health Centers, and also the College of Obstetricians and Gynecologists, all of which are primary care providers. We're here in support of this legislation based on its objectives, which is to begin to create a more comprehensive focus on the provision of primary care. We know that there's a number of amendments. We had some questions and amendments ourselves for the bill as drafted, but now there's a lot of amendments out there, so we'll be working with the sponsors and everyone else. to make sure that the framework, the composition, the charges of that commission are, look at the things most critical for enhancing and evaluating and supporting and maximizing our primary care services, things like differentiating between how you evaluate pediatric care versus other adult care, a number of types of provisions that we'll work with everyone, because there are a lot of amendments out there to frame something that'll achieve the sponsor's objectives.
Okay. Sometimes when there are a lot of amendments, it shows that there are a lot of people really interested in making a good bill better. Okay. We're going next to Suzanne Schlockman, Maryland Citizens Health Initiative Education Fund.
Thank you, Chair Kelly and members of the committee. I'm here on behalf of the Maryland Healthcare for All Coalition and on behalf of consumers in support of Senate Bill 734. You often see us here testifying in support of bills to expand coverage, and thanks to your leadership and votes for the reinsurance program and subsidies for low-income young adults, we have made tremendous gains in coverage, and we're thrilled with that. Thank you. But what we're learning is, coverage is not synonymous with access, and primary care plays a very important role in that. So we're very, very excited to be here in support of this bill today. We simply offer an amendment to not forget the consumers in this, the very important side of that primary care equation. We're happy to be at the table, and we also would ask that representatives of healthcare workers serve on the commission as well. But we urge your favorable review.
Thank you. Don't see any lights on. So thanks to this panel. We'll go next to Ben Steffen, and why don't I call up Steve Wise and finally Matthew Chalentano. Okay.
Thank you, Chair Kelly, members of the commission. Ben
You want to
Steffen,
pull your mic over so it's in front of you.
Yeah, we kind of have the Putin seating arrangement today. Ben Steffen, Executive Director of the Maryland Healthcare Commission. I think that Senator Lamb's panel said everything pretty well. I'm here to tell you that the Healthcare Commission is committed to convening this primary care work group if the Senate and the House pass this legislation, which the Commission supports. We think this is even so important that even if the Senate and the House don't act, that the Healthcare Commission would be willing to act should the chair of Senate Finance or the chair of HGO send us a letter requesting us to start this effort. The Healthcare Commission has as a strategic priority the elevation of primary care, and we've been working in that direction for more than 10 years. As importantly, our framework has always been to look at all of the issues that the Healthcare Commission addresses through the prism of health equity, and that would be a priority as we move forward, considering options for expanding primary care services in the state. Lastly, the healthcare data that is essential to much of what the work in this commission will, this work group will focus on is already assembled by the Healthcare Commission and can be accessed by our staff and our collaborators at the Health Services Cost Review Commission, the Maryland Department of Health, as well as the Maryland Insurance Administration, all of whom use this information for policy purposes today. So we are very committed to this work. We think that we have the experience and skills, and our contractor, recently awarded, has been heavily engaged in the 6 New England states with developing approaches in that region of the country to expand primary care. We think they are perhaps the most skilled group in the country in terms of using insurance claim and counter information in measuring utilization of primary care. We strongly support this legislation as amended by Senator Lamb. Thank you.
Thank you. And Steve Wise?
Thank you, Madam Chair. Steve Wise here today on behalf of the Maryland Academy of Family Physicians. We are very supportive of this effort. There's obviously been any number of amendments discussed today, and we have a few of our own that are technical, but also making sure that the Academy is included at the table. We'll take a little bit of time, hopefully, to evaluate those, but very supportive of the effort and look forward to participating, whether it's a work group, commission, or simply a letter from the chair. We'll be at the table. Thank you.
Thank you. All right, and Matthew, you're going to wrap up, and you have some concerns for the League of Life and Health.
Thank you, Chair Kelly. My name is Matt Celentano here today on behalf of the League of Life and Health Insurers. We were opposed to the bill as introduced, but with the MHCC amendments, we would be favorable.
Fantastic. All right, that's good collaboration, working together. And seems like a very important goal, and we're glad to hear that. And thanks so much. All right.
Thank you.
All right, we're going next back to Senator Lamb for Senate Bill 634. Home test kits for sexually transmitted diseases required coverage. And let's see, you got a panel, Dr. Elizabeth Gilliams, Dr. Charlotte Gatos, and Dr. Stephen Berry. All right.
Thank you, Madam Chair. And I'd also like to invite Dr. Miranda Kessler up here as well. She's the Chief Medical Director of Student Health at Johns Hopkins, part of the panel. So I'm happy to kick this off. Thank you, Madam Chair. This is Senate Bill 634. For the record, I'm Clarence Lamb, Senator District 12. Senate Bill 634 will expand benefit coverage for home test kits for sexually transmitted infections, or STIs, and the associated laboratory processing fees by an eligible individual's insurance. This at-home option, also called self-testing or direct access testing, will increase access for individuals to receive STI tests and assist patients in utilizing their existing health insurance coverage to defray the costs of these important tests. Home STI kits typically utilize a blood sample, urine sample, or superficial genital swab to screen for one or more STIs that do not require for the sample to be collected in a clinical setting like a doctor's office or laboratory. If the test result cannot be delivered right away through the kit, the sample that's collected is placed in an envelope provided by the kit and shipped to a laboratory for testing. The bill authorizes coverage for kits that are recommended by the Centers for Disease Control, as well as the U.S. Preventive Services Task Force and approved by the FDA. This bill not only authorizes insurance coverage for current tests that are available on the market, but also sets the regulatory framework for future recommended test kits that could be available as new scientific tests are developed. SB 634 improves access to STI testing, which can be limited by several factors, such as stigma, convenience, and scarce access to providers. These home test kits also help alleviate the strain that we are seeing right now in our clinical settings due to shortages of healthcare workers by reducing the number of clinic or urgent care visits for something that can be addressed simply with a simple test kit at home. That being said, these tests do not replace the role of a healthcare provider in prescribing appropriate medications or counseling should the test come back positive. And thus, in addition to increasing access to healthcare services, this bill, as introduced, helps mitigate the concerns of proliferation of STI throughout the state. Maryland has seen a 51% increase in the cases of chlamydia, gonorrhea, and syphilis between 2010 and 2019. The state is also ranked 7th nationally in cases of HIV diagnoses. These high levels are concerning because undiagnosed and untreated individuals, especially those with asymptomatic disease, pose a serious health concern not only to themselves but also to the public. We've seen a flourishing home test kit environment as we continue to battle the current COVID-19 pandemic, and as a result of COVID, many patients are now much more familiar with home test kits, which have been convenient and effective in reducing access to needed tests. This bill builds on that familiarity and comfort with home tests by mandating that needed STI home test kits that are ordered by a provider be covered by health insurance. This is not novel, as California has recently initiated a mandate for health insurance coverage of home STI test kits. Data indicates that prior to COVID, research has shown that the testing rate with home-based STI screening was up to 10 times greater than such testing with clinic-based screenings. So in closing, Senate Bill 634 will aim to lower these rising infection rates in the state by creating new opportunities by which STIs can be identified to mitigate their spread and help enable individuals to obtain treatment earlier. At-home testing is a mechanism for identifying these STIs, particularly asymptomatic cases, those without any signs, and is a critical component of reducing transmission. It's a necessary public health measure, I believe, that Maryland can take to stand to help further control the spread of infectious diseases. I would like to thank my sponsor panelists, Dr. Liz Gilliams from the Baltimore City Health Department, Dr. Charlotte Gatos to my left here, who is renowned when it comes to these home test kits, Dr. Stephen Berry from Hopkins Department of Infectious Disease, as well as Dr. Kessler from the Chief Medical Director of Student Health at Johns Hopkins. And with that, let me turn it over to Dr. Gatos.
Well, just before you do,
Sure.
I have one question.
Of course.
As I listen, if I'm understanding the value here, is there a connection possibly with 787 that Vice Chair Feldman had, the the HIV post-exposure prophylaxis kit or whatever that was? Is it?
I think that's a little bit different. So
I wondered if people found that they had an exposure, and then if we also had, well, maybe your kits could help to determine that they've had the exposure that he's trying to deal with there. I just wondered, the two of you may want to talk some.
It's a good point, and I think we're all trying to move in the same direction with that. I think I'm not familiar with the bill, so just based on your description, I'll take a closer look at it. It sounds as though that bill is focused on post-exposure to HIV and being able to self-administer tests at home when it comes to that. This is broader, so this expands it to things like chlamydia, syphilis, gonorrhea, and the like. And I believe those HIV tests probably could be conducted at home. Some of these tests actually need to be sent back into a lab for processing. So there's some slight differences there.
Okay. All right. Thank you.
Sure.
All
Dr.
right.
Gatos?
Well, we're going to your panel members next. So Dr. Gilliam.
Can we take Dr. Gatos first?
Okay. All right. That's fine. We'll do that.
Chairman Kelly and Senators, thank you for allowing me to testify today. These words are my own opinions. As most of you know, sexually transmitted infections are epidemic in the United States and in Maryland. CDC estimates there are 1 million new cases of STDs every year in the United States. In Maryland, there were nearly 50,000 cases of chlamydia and gonorrhea that were reported in 2019, 800 cases of syphilis, and about 724 people have been diagnosed with HIV during 2020. These infections are associated with severe sequelae. New molecular tests have permitted individuals to collect their own samples at home even, or in a clinic. Please differentiate between home testing, which is like an HIV test that can be performed at home and is approved by the FDA, and home collection, which is where someone collects the sample at home and mails it in to a laboratory for testing. Many commercial companies have developed internet recruitment of people to get home testing or home collection of samples. Some universities also, like our Want the Kit program at Johns Hopkins, have also developed these programs as public health screening, and these are for free. We've tested more than 10,000 people in Maryland since 2004. During COVID, I Want the Kit increased 645% compared to pre-COVID. These tests are not covered by insurance, and sustainability is a huge future issue. In conclusion, making these tests billable to insurance by law would be game-changing, and passing this bill will enable more persons with insurance to get tested for sexually transmitted infections. Thank you.
Thank you. All right. I don't see any lights, so they understand. All right. We're going next then to Are you Dr. Elizabeth Gilliams?
Dr. Gilliams,
Okay,
yes.
okay.
Thank you, Chair Kelly, and thank you, members of the committee, for the opportunity to testify today. I'm here on behalf of the Baltimore City Health Department, and I'm the medical director for sexually transmitted infections services at the Baltimore City Health Department Sexual Health Clinics. As Dr. Lamb mentioned, sexually transmitted infection control is a public health emergency in Maryland. And in the most recent report by Maryland's surveillance report, the total number of cases of gonorrhea and chlamydia and syphilis increased 51% from 2010 to 2019. While Maryland has made steady progress to reduce rates of new HIV diagnoses, every tool is needed in our kit to drive that rate to zero. Access to testing is the catalyst to diagnose, treat, and prevent onward spread of STIs. In high prevalence populations, over 50% of gonorrhea and chlamydia infections have no symptoms at all, highlighting the need for screening tests. Underdiagnosed and untreated STIs can lead to serious health consequences, including infertility, pregnancy complications, birth defects, and infant blindness. Furthermore, the presence of an STI can increase the risk of HIV acquisition and transmission. SB 634 promises to enable increased access to HIV and STI testing by moving it out of the four walls of a clinic. At-home testing has been shown to be safe, effective, and patient-centered model and is promoted by the CDC, and as per Dr. Gatos's research, has been shown to be acceptable by many folks. At-home testing overcomes the barrier of time, transportation, and stigma of seeking facility-based care, and hurdles like childcare, transportation, getting off of job for work during clinic hours are all issues. Lastly, SB 634 will lessen a cost burden that currently makes at-home testing unfeasible for many. An at-home HIV STI test kit, just looking online, can currently cost over $100 out of pocket. COVID-19 has spurred the rapid expansion of at-home testing, and demand has not declined, even with restoration of sexual health services. I'd like to thank the committee for this opportunity to testify and happy to answer any questions.
Okay. You must be very good with your explanations. I don't see any lights for questions. So we'll go next to Dr. Stephen Berry.
Thank you very much for the chance to give testimony. I'm a 15-year veteran HIV and primary care provider with the same amount of experience diagnosing and treating STIs. I want to spend my time drawing the very informative comparison between home STI and HIV testing and home COVID testing. First, there's nothing magic about needing a medical provider to swab any of the sites needed for STI or HIV testing. Many people here are probably used to putting a swab in their nose and twirling it around for a COVID test at home. As years of Dr. Gatos's research and others have shown, people are equally effective at swabbing a needed body site for STI testing and HIV testing as a provider is in the clinic, and most people prefer to collect their own specimens. Next, there's nothing magic about the actual laboratory test that gets performed on a self-collected specimen versus one collected in the clinic. They're often mailed to exactly the same laboratories, which have outstanding reliability and accuracy in test performance. Now, what is splendid about the idea of having insurance be required to pay for home testing is that it is likely to greatly increase testing in the community with a chance to prevent disease and transmission. Like COVID, STIs and HIV start out asymptomatic, and most transmission occurs when people are asymptomatic. Current treatments for STIs and HIV are tremendously effective at preventing the devastating long-term outcomes of these diseases and are 100% effective at preventing transmission. Like COVID, people know when they might have had an exposure, and they like to seek access to testing. Like COVID, however, if you're feeling well, the time spent needing to get to a clinic to get tested is a major barrier. Even more than COVID, the stigma that is associated with going to a clinic for STI testing or HIV testing is a giant barrier to coming in. Studies have shown, and I can attest from my years of experience, that many people put off coming in for years or never come in at all before it's too late, and the chance to prevent their own disease and prevent transmission to others is lost. When home COVID tests became widely available and easily affordable or even free, people rushed out to get them in order to take power to test themselves when they thought it was appropriate to do so. Requiring insurance to cover home STI and HIV testing is likely to be associated with a similar uptake in people being able to test themselves at home when it matters and having the chance to prevent disease for themselves and transmission to other people.
Your testimony is very compelling. I hate the fact that we've got so many bills that we have to limit time, but you're about a minute over.
Thank you. I strongly support this bill, and I'm done at that point.
Okay, thank you. We're going next to
Dr. Rowena Kessler.
Dr. Kessler.
Good afternoon. Thank you, Chair Kelly and Vice Chair Feldman, for this opportunity to testify in support of Senate Bill 634. My name is Rowena Kessler, and I'm testifying in my professional capacity as a college healthcare provider. I'm here today to urge a favorable report on Senate Bill 634. I'm the Chief Medical Director for Johns Hopkins University Student Health and Wellbeing. I oversee the campus primary care services for all of Johns Hopkins University students and learners. The views I'm expressing today are my own and do not necessarily reflect the views of Johns Hopkins University or Johns Hopkins Health System. As mentioned before, the CDC, the Maryland data, and the American College Health Association data are all showing that STI rates are increasing. Almost half of new infections occur in individuals who are 15 to 24 years old, which is why this is particularly relevant to the college-age population and also the college health providers that serve them. As we know, if not for STI screening, many STIs will go undetected and untreated, and they can spread widely in the community, especially in a campus community. In a typical year, about 10% of our visits, or over 1,000 visits at the Homewood Health Center, are STI related. There are probably many, many more students that never pass through our doors because of concern about stigma and also about potentially invasive exams to collect specimens. This is particularly salient for our transgender and non-binary students, who we know have higher rates of STIs, but who are also very fearful of seeking health care for concerns about discrimination. As mentioned before, the COVID pandemic has accelerated the use of home testing, and we think that innovative approach will definitely decrease the barriers to care. And by insurance covering it, it will also diminish the financial concerns. Thank you for the opportunity to speak today. I respectfully urge a favorable report on Senate Bill 634.
Thank you very much. And now we do have one unfavorable from the League of Life and Health Insurance, Matthew Tellington.
Good afternoon again, members of the committee. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers of Maryland. We respectfully are in opposition to Senate Bill 634. We're opposed to the bill as it presents consumers a confusing way to approach their care and potential cost implications we are not sure have been thought through. First, the bill is a new mandate on health insurance, and we would ask the approach be sent to the Maryland Healthcare Commission, like all other mandates, to analyze the impact on premiums. Two, we're concerned that while the bill seems like to create a convenience, it creates complex insurance operational concerns. Balanced billing concerns are a very real problem in this particular issue. How would the patient know if the labs used by the at-home tests are in-network or not? In the COVID space, prior to the mandates on testing, we saw some testing companies charging thousands of dollars a test. Insurers work really hard to build lab networks for in-network costs, to build relationships and to manage those costs. This approach sort of undermines that. And some of these at-home companies have their own labs. They could charge anything, and no consumer would know if it was in-network or not. They can charge anything they want to the consumer. There's no control. Also, if the consumers were to purchase the kits at a pharmacy, they will have reimbursement issues as well. Pharmacies in general are not connected to your medical benefit. It's a different bucket, and there's no established relationship there. Also, what happens after you get the test? If you're positive and you need a prescription, could the provider want to do their own test as well? So you're going to have duplicative care. In the example of the COVID test, it's very, very different. If you get a rapid test at home and you swab your nose and you find out you're COVID positive, the first thing the doctor is going to say to do is go get a PCR test. We're going to see duplicative prices, and it's going to drive premium. Lastly, because the bill requires the kits to be determined as medically necessary, which we definitely appreciate in the front end of the bill, the insurers are already paying for them, that if it was at a provider. If you went to your doctor, we're going to pay for it already. It's medically necessary. And the turnaround time on these tests will be far shorter than doing it at home, sending it, waiting for the results, getting it back. If you go to your lab or go to your physician and get a lab test, it can be done that day. In addition to that, by going through an already established process with your doctor and network labs, we don't have to worry about the balanced billing concerns. Home test kits may also not test the full range of potential STDs because of the nature of the at-home tests. If you go to a lab that is with your doctor, they're going to test for everything. You're going to get full results, and it's not going to be inconclusive. It's just going to take a lot longer than going through the normal inpatient setting. So that being said, we obviously want our beneficiaries to discover if they might be sick or have an STI, but this bill and this approach through home testing we think is the wrong approach. So we ask for an unfavorable report.
Senator Kramer?
Thank you, Madam Chair. So, Matt, have you met with the bill sponsor to see if, rather than just come in and say, the insurance industry opposes this because the insurance industry always opposes anything that involves them?
Well,
have you met with the sponsor to say, hey, maybe here's the path to get us to where you want to be, to ensure the opportunity for people who may be at risk of harm, get tested, and do so in the privacy of their home with a test kit that obviously, from what we heard, can be very effective in the diagnosis. So have you met with the sponsor and said, you know, Senator, there may be a way for us to get there. Let's put our heads together. He's a pretty bright guy. You're a pretty bright guy. So how about maybe, I'm just asking, has that occurred?
So, Senator Kramer, we reached out, and my assistant reached out, our office reached out multiple times and did not get any response on this particular bill. This is something that we think is appropriate to have a discussion about. We certainly want medically necessary coverage to happen, and we want people to get it in the proper setting. But we are concerned about the balanced billing, and the only way to address that in this bill is to make sure that the kits are linked to in-network labs. That makes it get much more complicated when you're buying tests online. But we'd be willing to have that conversation for sure.
All right, so you are now committing, right here, right now.
You got it, sir.
To have that conversation.
Yes, I would have liked to have had the conversation 2.5 weeks ago when we reached out the first time.
All right, well, I'm confident now that the good senator who's the sponsor of the bill would be happy to have that conversation, and maybe there's a pathway that gets us to where we all can benefit. So thank you for that, Matt.
Thank you, sir.
Matthew, one thing that you said, which I'm sure from your perspective is a problem, but I want you to think about one other aspect, and that is you said they ought to get the appointments with the primary care physician, and they could get maybe a fuller panorama or view of any other things they might have that are similar. It takes so long now, and since COVID, it's even much longer to get an appointment, an in-person appointment with a primary care physician. I have in my district some elderly people that I know well and who work my campaigns who are having a hard time getting to people that have served them for 15 or 20 years, and they really have symptoms that sound pretty bad to me.
Right.
And they're calling, asking, can the General Assembly do anything to make doctors see you sooner? Because people are telling them 6 weeks and 7 weeks. So if you have something,
Senator Kelly,
something, it could get worse and cost you in the long run more.
Sure.
Though I'm sure you got to be sure they're your
Right.
insured and not somebody else's.
Well, I think there's a couple of different ways to approach that question, and I do agree with you, Senator Kelly. COVID has changed everything, especially with primary care. But this bill wouldn't really change anything with that because it would have to be considered medically necessary and ordered by a doctor. So you're going to have a touch with a physician at some point. I think telehealth has certainly changed access issues on that, and if somebody can get a telehealth appointment with a doctor and explain their symptoms, then the doctor would be able to order the test. But with this bill, that doesn't change the fact that a physician has to order it after it's deemed medically necessary.
I'm having people complain it's taking them a week and 10 days to get somebody to call them back when they go online.
Well, if MedCai would like to come to the table and talk about that, I'd love to.
The other thing is, maybe about 65% of the public doesn't have internet service. In Baltimore City, there are whole sections of the city with no broadband.
Sure.
In northern Baltimore County, up in the horse country, where people have some money, but they don't have broadband. So, so I hope that maybe the two groups can get together to figure out what can be done, because it would make sense if there is a way around. And obviously, you have legitimate concerns as insurers. You want to be sure you're covering your own people.
We want to make sure that consumers don't get, a ridiculous out-of-network balance bill charge too, and that's a really big concern because consumers won't know, and all of a sudden they'll get this charge that they're responsible for, and we want to prevent that.
So could I ask that of everybody who's testified on this bill in either direction, to raise your hand if you're willing to talk, to see what you can come up with? Okay. Then we'll try to have you.
Thank you very much.
Okay, thank you. All right, Senator Reedy, you're up next for Senate Bill 688, Health Insurance Utilization Review for Coverage of Prescription Drugs and Devices Expedited Appeal.
I believe.
Okay, let me call them. Diana Kaufman, Robert Herman, Joseph Collins, and Jennifer Durr. So at least three of. I tell you what, your whole panel. Well, we'll take the rest of your panel later,
Okay.
or if you want to stand at the mic and talk,
Let's do it.
then your whole panel can sit down now.
And Madam Chair, I'm going to present and have our folks present. At some point, I may have to slip out because apparently Ehi's going to be calling me in a couple
Okay, well,
minutes.
then we
So
want to get started. Is Jennifer Durr also here?
I'll get started.
All right, okay. Well, what about, all right. The only one I don't see is
There may be
Diana.
one that it couldn't make it.
She'll probably show
So,
up.
yep.
Go ahead.
All right. Thank you, Madam Chair, members of the Finance Committee. Senator Reedy here to present to you Senate Bill 688, which is Health Insurance Utilization Review for Coverage of Prescription Drugs and Devices Expedited Appeals. When a physician or other clinician prescribes medication or treatment for a patient, the patient's insurance company or pharmaceutical benefits manager requires prior authorization before approving coverage. We've talked already a little bit about prior authorization today. While prior authorization is promoted as a healthcare savings mechanism, this process allows PBMs and insurers to impose extensive paperwork requirements, multiple phone calls, and significant wait times on prescribers and their patients. As doctors in Maryland continue to be, as we've just discussed, in a very difficult spot because of the pandemic, overwhelmed at times with the need and the need for mental health treatment also is growing. Eliminating burdensome requirements would alleviate a fraction of the stress on our providers and enable them to spend more time with patients in need. Prior authorization often leads to patients experiencing arbitrary limits on medications. When PBMs and insurers decide that patients should not get the treatment that the doctors have recommended, this is akin to practicing medicine without a license. Remarkably, there's no clear evidence that prior authorization improves the quality of patient care or saves money. And we've cited that in my testimony from the American Medical Association. Instead, it often results in unnecessary delays in receiving life-sustaining medications or other treatments, and it leads to physicians spending more time on paperwork and less time with the people that are most important to them and to us, their patients. For individuals with psychiatric disorders, including serious mental illness and substance use disorders, these kind of gaps in treatment can lead to relapse, increased healthcare cost, and obviously the most important or the worst thing, which is the devastating effect on that individual and their family.
So this bill does several things, and it's listed in my testimony. I'll touch on it briefly. It would eliminate prior authorization for generic medications that are not controlled substances. It would eliminate prior authorization for dosage strength changes of the same medication. Eliminate prior authorization for generic and brand drugs after patients have been on that medication for 6 months without interruption. It would require insurers and PBMs to adhere to a 48-hour appeal process so there's timely access to medication for patients. It would prohibit plans from denying medication on the grounds of therapeutic duplication if the patient has already been subject to review for that same dosage and it was previously approved. And then finally, the sixth thing that this is in this bill, and it is a substantive bill, it would require denials and denial reviews to be conducted by physicians in the same profession or similar specialty as the healthcare provider whose recommended treatment is under review. So in conclusion, I'm presenting this bill because patients need timely access to necessary medication. And as for your support on the bill, I understand we have a lot of support. We also have opposition. We're very open to discussing ways that we can make this work, but it's very important, and it's costing a lot of difficulty for patients and doctors. I had one example that I've heard about a 17-year-old patient of one provider who had recent inpatient psychiatric hospitalization. The patient was started on additional medication for mood stabilization while an inpatient, even though this doctor saw him for a follow-up appointment. But the father alerted the doctor that the patient had not continued a medication outpatient because the pharmacy did not fill it. The doctor called the pharmacy, and the medication required a prior authorization. In the meantime, prior to the patient coming back to see this doctor, he had several days of not being on medication that had helped to stabilize him so he could be discharged from the hospital. And it's incredibly dangerous. And so this doctor that gave me this example, I thought was very compelling. It's dangerous, and it's not an isolated incident. So again, that's why we have the bill here before you today, and I turn it over now to my panel of witnesses who know much more about this firsthand than I do, but I'm happy to answer questions as we move forward, until I may have to slip out at some point, Madam Chair, and my apologies for that.
Are there any questions for the sponsor? Okay, seeing none, we'll go to your panel, and you each have 2 minutes. Okay. All right, Robert Herman.
Thank you. My name is Robert Herman. Thank you, Chairman Kelly and Vice Chair Feldman. I represent the Maryland Psychiatric Society, which is the district branch of the American Psychiatric Association. I am a psychiatrist. For over 30 years, I have treated the full spectrum of psychiatric illness, including depression, bipolar disorder, schizophrenia, post-traumatic stress disorder, and alcohol and drug dependence. Prior authorization of medication harms my patients and their families. It results in the delay or denial of care, which has serious consequences for my patients and their families. This includes poor work performance and loss of job, suicide attempts, altercations with family, legal problems, psychiatric hospitalizations, and unnecessary suffering. It's a heavy burden on me and my colleagues who are already facing greater burdens as a result of the increased mental health problems due to the pandemic. This bill would not eliminate this burden, but it would make some common sense reforms that would lessen its harmful impact. The rules that pharmacy benefit managers use to make coverage decisions are opaque. They don't follow evidence-based guidelines. They differ from plan to plan. They change from year to year for unknown reasons. They have no bearing on the welfare of the patient. When I prescribe a medication, the decision is often reviewed by a physician who has never trained in or practiced psychiatry. For example, a retired radiologist denied medication for a patient with bipolar disorder who had severe depression. A pediatrician denied medication for an adult with opiate addiction. I have to do prior authorization for inexpensive generic drugs like generic Prozac, which at some pharmacies cost less than $4 a month for cash price. The time to complete these authorizations takes away my time in caring for patients. I'm also forced to repeat prior authorization when I simply want to change the dose of a medication that was already approved. This, again, is irrational and takes away time in caring for patients. These procedures are especially burdensome for the patients that I care for. There is still stigma and shame associated with psychiatric illness. This, as well as the illnesses themselves, such as severe depression or anxiety, make it very difficult for my patients to advocate for themselves. We must therefore advocate for them and pass this bill.
Okay. Let me just ask a question. The way you're operationalizing the definition of prior authorization, would it include, let's say you see a new patient for the first time, you've gone through the battery of tests of whatever you do in order to assess the patient to decide what the medical problems are, and you provide a prescription. It's the first prescription you've done for this patient. In a case like that, how is prior authorization involved if it seems as your prescription?
Yeah, I'll tell you, so if I see a patient and after I do a psychiatric examination, do a history, find out what they've been treated in the past, all of the things that I've been trained to do and I've done for 30 years, I will write a prescription and send it to the pharmacy. Many times, I will then get a message from the pharmacist who tries to put through a claim for the medication paid for by their pharmacy, and the message will be that it requires a prior authorization. So there are ways to do it. One way is I have to call a phone number and they put me on hold, and then they put me on, online with some person that they ask the questions and things like that. We commonly do this electronically. If there's a company in Ohio called Cover My Meds, and if the pharmacist goes to Cover My Meds and starts the process, then it gets sent to me electronically with a form that I fill out. And then I fill out the basic parts of the form, and then it goes, and then 24 hours later, I get a form that fill out, and it asks certain questions like, what is the patient's diagnosis? What is the patient's age? Other things like that. And then I submit it electronically, again, to the pharmacy benefit manager. And then they issue a decision, and they might say, they might approve it, but still, it might take 2 or 3 days for that to happen. Or they might deny it, and they might say, well, the patient doesn't satisfy the criteria, or the patient must try, has the patient tried, and typically it's has the patient tried several drugs which are cheaper? And they ask for very detailed information. What was the dose of the drug that the patient took? Okay. How long did they take it? And these things delay.
And then one of your concerns is that you're dealing with these pharmacy benefit managers who are not physicians at all in many cases.
No, they're not. And they have, you don't know what the rules are of the game until you try to play it. And then sometimes you'll get a rejection, sometimes you'll get an approval. And it changes from year to year. It changes from company to company.
Let me ask this. In the course of a typical month, how many different PBMs might you need to respond to?
Well, now they're getting bigger and bigger. I think CVS Caremark, Magellan, what are other PBMs? My colleagues can probably help me. There's a variety of them. And, again, I mainly focus on the patient, so I don't have a directory of the different PBMs, and sometimes employers will change their PBM.
Okay. Thank you. I keep thinking the problem is really a national problem because the PBMs are operating all over the country, and it's just the luck of the draw as to what PBM might bother you on a given day or something that ought to be routine. And, okay.
Yes,
I think we need Congress to really...
I think we do, but we've been working on this bill with our national organization, the American Psychiatric Association, And they tell me that there are several states that have introduced or passed bills similar to this one that we're proposing.
Do you know if they're working, if these bills are making a difference in those? I'll tell you what, get back to us, if you could just check and find out
Okay, I will.
what states have done something, if you can find a bill number so we can see what they passed, and let's see what was working.
Yes.
Because I know this is a real tough issue and it's a national problem. Okay. All right, let's go next to Dr. Joseph Collins.
Thank you, Madam Chairman, Vice Chairman, and members of the Senate Finance Committee for this opportunity to speak before you all today. I'm Dr. Joseph Collins, a board-certified psychiatrist. I'm medical director of St. Luke Institute, what had been a residential, now an outpatient treatment facility for behavioral health in Silver Spring, Maryland. I also have a private practice in Bethesda, and I've lived and practiced in Maryland for approximately 30 years now. Prior authorization for psychiatric medications has been touted by some as a process that is intended to improve the quality of care for our patients. I question this. I often experience excessive prior authorization as taking time away from patient care, sometimes actually costing the patient more money, and frequently limiting patients' access to appropriate care. I brought a couple of clinical examples. One of my patients has a severe chronic insomnia that has been well documented by a neurologist who subspecializes in sleep disorders. He takes a generic form of Ambien and has been stable on this for years. Prior to his diagnosis and treatment, his insomnia had been so severe that he missed work for weeks at a time. While waiting for ongoing reauthorizations by his insurance company, he has on occasion paid out of pocket for the medication just so he won't go through his sleep-wake cycle being thrown off once again. So my patient ends up paying his insurance premium and then paying needlessly for his medication at times. This clearly isn't saving my patient any time or money. I happen to have worked at a college counseling center, and as a result, I also treat a number of young adults who have ADD. Many of them are stable on their psychostimulants and take them primarily during the academic year. They frequently run out of medication shortly before midterms and finals. Obviously, that's when they get in touch with me. A student who is either stable on their dose of a generic ADD medication or having the dose titrated with minor adjustments should not have to be subjected to repeated prior authorizations, losing precious study time during periods of increased academic stress. So in my own clinical experience, excessive prior authorizations and reauthorizations for prescriptions that have been proven to give a person stability at the current dose or making minor adjustments takes time away from patient care, often disrupts the patient's lives, and unnecessarily limits their access to appropriate, already approved treatment. Thank you again for your time, and I urge you to support SB number 688.
Okay, thank you. I don't see any lights on, so we'll go next to Dr. Jennifer Dorr.
Yes, thank you. Good afternoon, and thank you, Chairperson Kelly and honorable members of this committee. My name is Dr. Jennifer Dorr, and I'm a Child and Adolescent Psychiatry Chief Fellow. I'm asking that you support Senate Bill 688, as this is a priority bill to help to eliminate barriers currently in place that do not allow patients to receive timely mental health care. As a child and adolescent psychiatry fellow, I am on the front lines helping youth to battle the current mental health crisis affecting our nation. Having prior authorization requirements in place by insurance companies simply allows an insurance company's PBM to have the final decision on whether or not my patient receives the care that I'm recommending and prescribing. I've developed my treatment recommendations because I have assessed the patient fully, offered a diagnostic biopsychosocial formulation of the patient, their needs, and the appropriate treatments they require. And oftentimes, these treatments include medications. I am able to make these treatment recommendations based on my knowledge of the patient and the expertise and training I have obtained. Right now, I'm finishing my fellowship, and I am 16 years post-high school studies of training. In addition to the example that Senator Reedy provided, I do just want to add, studies have shown that patients are at an increased risk of suicide directly following hospitalization. So delaying medication at that time, and that was my patient, is not only dangerous and appalling, it's actually life-threatening. By way of another example, I have an 8-year-old patient who has been on medication for over 3 years. And since I increased the dose, it required a prior authorization. The insurance company denied the medication, stating it was not FDA approved for one of his diagnoses, despite knowing he was on this medication for over 3 years. Further, it is FDA approved for another one of his diagnoses. Meanwhile, the patient went several days without having his medication, which caused his mother great distress as she saw her child unable to sleep, having outbursts, and at times becoming emotionally dysregulated due to his lack of medication. Senate Bill 688 works to help move prior authorization requirements to only those that are necessary and eliminating those that are not. Thank you so much for allowing me this opportunity to speak. I ask this committee for a favorable report on Senate Bill 688, so to eliminate a barrier to timely mental health care treatment.
Are your national associations working on this in the Congress?
Yes,
'Cause
and
it is a
we work.
nationwide problem.
Well, the Congress, unfortunately, is not as responsive as the Maryland legislature.
I know, we just have less leverage when the problem is national. Okay, let me go to the unfavorables. Matthew Celentano and Camille Fetch. And they're really good guys, but somebody has worked for these companies.
Good afternoon again. Matt Celentano, still here on behalf of the League of Life and Health Insurers of Maryland, respectfully opposed today to Senate Bill 6088. We are opposed to this bill because utilization review is one of the best tools carriers have to ensure patient safety. It's literally the reason why we do it. The bill seems like an attempt to streamline that process, and we understand the desire, but we very much disagree with using a streamlining process that might sacrifice patient safety. The vast majority of commercial enrollees, about 85%, are in plans that limit prior authorization or utilization review to less than 10% of medications. Also, carriers use input from doctors on when to establish these guidelines. Health plans consult with specialists to develop the process, and the vast majority use provider-developed clinical guidelines in the first place. It is not to restrict access to medication whatsoever. An example is that there are several generic oncology drugs that are quite inexpensive, and proper utilization review may provide a better recommendation for a drug that's less toxic, less monitoring, different administration route, to the treating physician, who also brings an extra layer of safety, as all dosages are recalculated every time there's a new drug. Another example of why this bill misses the mark is a drug like Humira, who I'm sure many of you have heard of. It's the most often prescribed drug for the treatment of rheumatoid arthritis. It oftentimes fails to provide the clinical outcome desired by the provider, and after a number of dosage increases, that eventually leads to prescribing a product in a different therapeutic class. Having utilization review in place will bring an extra level of review of the clinical case that may bring the needed product on board a lot sooner, avoiding extra medical expenses and providing a better quality of life to the patient. We don't really know why this bill is being introduced as well. There is already a robust utilization review process in Maryland that incorporates a lot of the parameters in the legislation. We already have guardrails around who must do the utilization review in primary care, as well as laws in the specialty care. There are already doctors and specialists involved in the prior authorization process in 1510B07, so it's duplicative in nature. Like I said before, we are certainly in favor of making the most efficient process for stakeholders, but there are already a lot of existing laws that make this bill, we think, the wrong direction. So we respectfully request an unfavorable report on Senate Bill 688. Thank you.
Let me ask, do you, as PBM reps, are the PBMs having more of a problem when it's psychiatric as opposed to other fields of medicine?
Well, there's a PBM representative sitting next to me, but I would say that I was just speaking to the overall utilization review that applies to all drugs in the marketplace.
The answer to your question, Senator Kelly, I do not know where the prior authorizations and what areas they are, but I'd be happy to investigate that and get back to
We
you.
would appreciate knowing.
Sure.
Obviously, there are things that you gotta investigate in order to be sure you're paying for the right you're authorizing for the right person, and that they belong to the company that you have a contract with.
Sure.
And so on. But on the other hand, in some cases where people need almost emergency attention in terms
Sure.
of what the prescription is going to be, I keep wondering if there's some kind of a form that you could just have that doc fill out with whatever you're going to ask them later.
So I'm glad you asked that.
They put the prescription in.
I'm glad you asked that, Senator Kelly, because there already is a process. Under the Affordable Care Act, if the doctor requests an exemption from the existing prior authorization process, the carrier has to act and give you an answer to that question within 72 hours. If it's an emergency situation, it has to come within 24 hours.
Okay. The main thing is if they've got to do that, let's see, in the course of a typical week, 59 or 60 times, they're taking all their time up with the paperwork. Okay, well, all right, let's hear the other witness.
Sure. Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. For the record, my name is Camille Fash. I'm here on behalf of PCMA, the Pharmaceutical Care Management Association, which is a national organization that represents PBMs, or pharmaceutical benefit managers. Mr. Celentano has said a lot of what I was going to say, so I'll make a couple quick points because I don't want to repeat his testimony. As he stated, Maryland already has a robust utilization review law, and this law is in part duplicative and potentially conflicting with current code. It does take away the ability to see whether a particular medication is medically necessary, and this is something that protects the patients and protects the patients and make sure that they're not spending money on drugs that are not going to be useful or get them the result that they're looking for, or whether to understand whether or not there's another available option. And it does take away some level of safety because the utilization review does oversee all the pharmaceuticals that the PBM is involved in, because patients may fill their prescriptions at different pharmacies, and a potential provider or doctor may not know all of the medications that a particular patient is on. So we request a unfavorable report on this bill. Thank you.
Okay. Is there any state that you know of in which the PBMs have worked out something that is more accommodating, especially for those specialties where it could be a life or death difference if a person gets a needed prescription and timely, and if they do not?
I don't know, but what we have found is that sometimes when a doctor in Maryland is complaining about an issue, it may be that healthcare plan is governed by the laws of a different state, so whereas Maryland has a very robust, then we got 72 hours, 24 hours emergency, other states, other plans may be complying with more lenient laws of other states. One thing that would be important is to work with the MIA to see how many complaints they've received when it comes to prior authorizations and utilization review.
Or you guys heard that now, so you ought to contact the MIA if you're having a problem.
Well, I'd just like to add to that, too. If there is a problem with folks getting drugs, the carriers, we want to hear about it. And if there are delays that it's not happening, that's not improper. We want to be able to address that.
Because in a way, you're paying a fee to work with that PBM also and have them do your
That
due
is correct.
diligence.
Carriers contract with PBMs to do pharmaceutical services.
And we don't know under the current system if everybody is getting what they've got a right to have for given their role in the system, and if it's timely enough to be beneficial to patients.
I think that's a broader concept. It requires a different conversation, but I'd be happy to have that with you, Senator Kelly.
Okay, all right. Okay, no other questions. Thank you very much. That ends the testimony on that bill. Okay, and we're going next to Senator Klossmeyer, Senate Bill 707, Health Insurance Provider Panels Coverage for Non-Participation. And you've got a panel, Ellen Weber, Courtney Bergen, and Ann Gaddis.
Thank you, Madam Chair and Committee. Senate Bill 707, Health Insurance Provider Panels Coverage for Non-Participation. Senate Bill 707 would require any insurer subject to regulations by the state to cover the cost of mental health and substance abuse treatment that is obtained outside of the member's provider network at no greater cost to the member than if the services were provided in-network. This will eliminate the practice commonly known as balance billing, when the insurer approves the member to receive services from a non-participating provider. Maryland law requires that insurers must approve provider services out of network if services are not available from a provider in network without unreasonable delay or travel. When services are approved, the member gets the in-network deductible and copayment. The insurer and the provider negotiate a rate for the service. However, if the amount they agree upon is less than what the provider charges, the provider is allowed to bill the remaining balance to the patient. This practice, known as balance billing, leaves patients who have no control over the network with an unexpected and often unfavorable charge. This practice is not allowed for HMO policies, but still exists for PPO policies. 17 other states have laws that require carriers to cover the cost of out-of-network service at no greater cost to the member if the network is inadequate. The Maryland Health Care Commission would be required to develop a reimbursement rate formula to ensure that providers will be reimbursed fairly for non-participating provider services. Maryland should be the next state to provide this protection to guarantee that Marylanders are receiving the mental health and substance abuse disorder care they need without unexpected and unaffordable expenses. And I think that's the most important part there, the unexpected and unaffordable expenses that these folks get. I thank the committee for their consideration of Senate Bill 707, and I ask for a favorable report.
Are there any questions? Okay, seeing none, then we'll go to your panel. You each have 2 minutes. Ellen Weber.
Thank you, Madam Chair, and thank you, members of the committee. And we want to, I'm Ellen Weber. I'm with the Legal Action Center here on behalf of the Maryland Parity Coalition. I want to thank you for the opportunity to testify in support of SB 707, and we also thank Senator Klossmeyer for reintroducing this bill to protect consumers from unaffordable out-of-pocket costs when they can't find a network provider within a reasonable time or distance. As Senator Klossmeyer indicated, consumers have a right under Maryland law to get carrier approval to see a non-participating provider when a network provider is not available. But this right is really meaningless because consumers can be balance billed for the non-network service. We're very glad to hear that Mr. Celentano was concerned about balance billing for STD testing because few consumers can afford that. And with regard to mental health and substance use disorder services, that amounts to significant, unexpected, and unaffordable costs. Under SB 707, plan members get the full benefit of state-mandated mental health and substance use disorder benefits, ensuring that they would pay no greater cost than the cost of a network provider. And to ensure that non-participating providers can deliver those services, SB 707 would require the Maryland Health Care Commission to establish a reimbursement rate formula to ensure a fair and a defined reimbursement rate. Maryland does that already for HMOs, and it does that for assignment of benefits for emergency department services. Providers would not have to negotiate an agreement for each individual that would expedite entry into care. 17 states, those are listed in my testimony, across the political spectrum have this no greater cost standard, including our neighbors Delaware and West Virginia. It's also based on the National Association of Insurance Commissioners Model Network and Adequacy Act. This is the fair and right policy to address this David and Goliath situation. After 6 long years of trying to address limited networks through legislative and regulatory activity, consumers should not bear the cost burden of inadequate networks that they have no control over. This is particularly true when they pay high premiums for network costs. This state has taken important steps to address network adequacy, but much more can be done. SB 707 offers a necessary remedy for all Marylanders who are experiencing the greatest need ever for mental health and substance use service. We urge a favorable report on SB 707 to level the playing field and ensure that Marylanders get behavioral health benefits that they're paying for without life-threatening delays. Thank you very much.
Thank you. Are there any questions? Okay, don't see any. So we'll go next to Courtney Bergen.
Good afternoon, Madam Chairs and members of the committee. My name is Courtney Bergen. I'm a consumer of mental health services and I'm a resident of Baltimore City, and I'm here to testify on Senate Bill 707 because when I tried to seek mental health care services that literally have saved my life and changed my life in ways that I never even imagined possible, I had to contact over 50 in-network providers. I could not get coverage for a single in-network provider. No in-network provider would take me. So I started contacting out-of-network providers because I didn't have any options. But my insurer, when I went to them to ask if they would cover this, denied coverage for a single case agreement. They did authorize me to utilize the current network adequacy statute and go out of network. But unfortunately, because there's no prohibition against balance billing and no negotiation on the rate, it was going to cost me more to use the current network adequacy statute than to use my out-of-network benefits. I don't think that was your intention when you passed that law, and I don't think it's what should be happening. We currently are all struggling to access mental health care across the state, and I think we need to be doing more. And notably, when I didn't get approval to go out of network until I testified before this committee. And then my insurer agreed to negotiate a fair rate with my provider, but my insurance changed again a few months later and racked up $130,000 in hospital bills before they would agree to negotiate fair outpatient rates with my provider. That cost me a lot of money, that cost the state a lot of money, and that cost my life in terms of me getting set back a year in school and other things. And it could have literally cost my life. So I urge you to issue a favorable report on this bill so that all Marylanders across the state can access the care they need.
Okay. Are there any questions? Okay, I don't see any. So we'll go next to Ann Geddes.
Thank you, Madam Chair and committee members. My name is Ann Geddes. I'm with the Maryland Coalition of Families. Our staff provide family peer support to families with a child or other loved one with behavioral health needs. And I'm here in support of Senate Bill 707. The mental health of children and youth has been especially hard hit by the COVID-19 pandemic. Statistics reflect the growing problems, increased utilization of emergency departments for psychiatric crises for children and youth, increased suicides for youth aged 10 to 14, and increased self-reports of suicidal ideation by adolescents. In the fall of 2021, the nation's leading health experts in pediatric health declared a state of emergency in child and adolescent mental health. Therefore, not surprisingly, our staff that support parents and caregivers have reported seeing a dramatic increase in the number of families with children who are on waiting lists to receive counseling from a mental health provider. Waiting lists of 3 to 4 months are not uncommon, and some are longer. Some of these children are cycling in and out of crises while waiting to begin treatment. Families don't know, because no one has told them, that they have the right to see an out-of-network provider in these circumstances. I'll just briefly give one example. A family that I interviewed whose daughter had experienced significant anxiety and depression issues post-COVID, went to her insurance carrier and was given a list of providers. She told that all those providers were taking new patients. She called them all, the whole list. None of them were taking new patients. So she called the carrier back, and their advice was that she should call her ex-husband's EAP to get help. Eventually, what she did was found a grant program, actually a grant program, to get counseling for her daughter. Children should not have to linger on waiting lists for months before getting treatment. Senate Bill 707 would require insurers to explicitly inform families of that right. But it is not enough for parents and caregivers to simply receive permission to see an out-of-network provider. They should also have the right to pay that out-of-network provider what they would pay to see an in-network provider. It should not be their fault that their insurance carrier has an inadequate network. They should not bear the burden of what is not their responsibility. Insurers should. Therefore, we urge a favorable report on Senate Bill 707. Thank you.
Okay. Are there any questions? All right, you guys are very clear about what you want. Okay, thanks to this panel. We next will hear from Hallie Rigscala, Paul Berman, Andre Pellegrini, and Dan Martin. Okay. Are you Paul Berman?
No, I am.
You're Paul Berman.
Sorry,
All right.
I came up a little bit early.
And was Hallie Rigscala here? Okay, I guess that person is absent. Okay, and Andrew Pellegrini?
Andre Pellegrini, yes.
Okay, all right. Okay, go ahead.
Well, good afternoon. Thank you to the chair and members of the committee for taking my testimony in support of this bill. I'm a provider of substance abuse and mental health treatment in Baltimore City. And I'm here to tell you why people have to call 50 different providers to know which one is going to accept them. I want you to picture 30 patients who have a substance use disorder whose treatment has to be interrupted because commercial carriers do not pay their claims. That's only one of the problems that we face with commercial carriers. The very first issue with commercial carriers is becoming in network with them. That's why there are not enough providers in network. It can be extremely hard and frustrating to get a contract with commercial carriers. Not all of them, of course. But think about working with a commercial carrier for 1 year just to have your contract rejected. That's probably the number one issue that providers of mental health and mostly substance abuse face with commercial carriers. The second biggest issue is the lack of transparency. It's impossible to know how much commercial carriers will pay for services that we render, and if they will pay for the services that we render. After figuring out if they will pay or not, then the battle starts with them paying their claims, which a lot of times commercial carriers come up with many reasons not to pay for substance abuse and mental health treatment. Think about these patients whose treatment I have to interrupt because their plan would not cover their bill. Because of these reasons, I urge this committee to pass this bill. Thank you.
Okay, are there any questions? Senator Klossmeyer.
Can you, Andre, tell me about the rates that the commercial carriers pay? Are they reasonable? Are they more money or?
So when you know what so that's the first disincentive for providers to get in network with commercial carriers. You do not know how much they will pay until you set a contract with them. They usually, it depends. It really depends on the codes. It really depends on the region that you operate in. But it's frustrating because you have no idea what they will pay.
Okay, thank you.
Any other question? Okay. All right, let's go to Andre. You're on.
That was me.
All right, let's go to Dan Martin.
Madam Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland here in strong support of Senate Bill 707. And I guess all I can say is here we go again. Versions of this bill have been in front of you a few times, 2019, 2020, again today. And the reason is simple. Despite all of the efforts, things that the legislature has done, the Maryland Insurance Administration, things that the carriers have done on their own accord, despite all those efforts, Marylanders with commercial insurance still, to a large extent, cannot access in-network mental health and substance use care when needed. According to the findings from an independent national report in late 2019, Maryland is among the worst states for access to affordable in-network care, behavioral health care, and I refer you to my written testimony for that data, an infographic on that data, and actually some of that data speaks to Senator Klausmeier, what you were asking. That report showed that Maryland behavioral health providers received, on average, 18% less than other doctors for similar billing codes. And there are ongoing efforts both within and without the legislative process to address these network adequacy failures. I'm confident you're going to hear from the carriers who will tell you all the efforts that they're engaged in, and it's great. Those are all very positive things. But until we really do get a handle on it, while the advocates, while the legislators, while the states, while the carriers, while we're all working to resolve this issue, it's Marylanders with commercial insurance in need of mental health and substance use care who will be the ones bearing the burden and feeling the pain. They are the ones who will be forced to pay high out-of-pocket costs on top of the health insurance plan that they're already paying for, if they can afford it. You know, some won't be able to afford it, and they'll forego care altogether. And so until we do find a solution, urge you to support and pass Senate Bill 707 so that Maryland consumers are held financially harmless when they have to go out of network for mental health and substance use care. Thank you.
Okay. Are there any questions? Okay. And Paul Berman.
Thank you, Madam Chair, members of the committee. My name is Paul Berman. I'm a psychologist in practice in Baltimore County. Also work part-time for the Maryland Psychological Association. I'm here in support of Senate Bill 707. 707 solves a problem for consumers when they're forced to go out of the network because providers in the network either don't or not able to see patients within a reasonable time or reasonable distance, or do not have the skills necessary in order to deal with the patient's problem. Here is the problem that Senate Bill 707 is trying to solve. When the consumer sees someone in the network, their out-of-pocket payment, their copay is fixed and typically reasonable, $25 or so. But if they're forced to go out of the network and see someone out of the network, then their copay is the difference between what the insurance company pays and that practitioner's usual fee. So, for example, if someone goes out of the network, is forced to go out of the network, and typically the insurance company pays $60, that's their portion for an in-network person, and the patient is seeing someone out of the network now, and their fee is $200, then the insurance company pays $60, and then the consumer who is forced to go out of the network because the insurance company's network is not adequate is faced with a bill of $140 that either they pay or they make the decision not to proceed with treatment. If the network is not adequate because of decisions made by the insurance companies, the consumer should not be left with the bill. Senate Bill 707 solves this problem by making sure that the consumer in these situations pays no more than they would if they were seeing an in-network therapist, and the insurance company then would pay the difference between that patient's copay, the usual copay, and the fee set by the Maryland Healthcare Commission. You may hear from insurance companies that they've tried to get therapists into the panel and to join the panel, but they can't. The problem is very simple, members of the committee. They're not willing to pay enough. In 1990, when I started in practice, the average fee for a session was $95. If you just take inflation into account, that is $205 today. The average fee paid by insurance companies, or the maximum paid by insurance companies, is between $85 and $120. So that's about a 50% cut from what the fee was in 1990. That's the problem. They're not willing to pay enough, and with all due respect to the insurance companies, if they paid the prevailing rate, they would have no problem getting providers onto the panel. So for these reasons, we urge you to report favorably on Senate Bill 707. Thank you very much.
Let me go back to Dan Martin and ask you something. Since you had a statewide organization, our Mental Health Association, do you know of any other states that either have some kind of a state hammer that they're using to make sure the networks are adequate for mental health treatments? Or do you know of one that has a workaround if a patient finds themselves out of network because it can't be seen in reasonable time and that they can't afford?
Well, I think there are other states doing innovative things to expand their networks. I had to report back on some of the different things that they're doing, but so I think there are a lot of states, many other states, that have some things like this, the provisions in this bill that hold the consumers harmless when the networks are inadequate. And I think Ms. Weber's testimony probably has a lot of those other states kind of listed in her testimony. So I don't think we would be alone in passing something like this.
Okay, well, just make sure that we get the list of states that are doing something that is a fix the way you see it.
Sure.
Okay. Are there other questions? Okay, if not, all right, that's the end for this panel.
Thank you.
And we're going to call up Matthew Celentano and Allison Taylor.
Madam Chair, Allison Taylor had a sick kid and is not going to be able to join us this afternoon.
Okay.
Madam Chair, members of the Finance Committee, Matt Celentano, here today on behalf of the League of Life and Health Insurers of Maryland in respectful opposition to Senate Bill 707. We understand the frustration of the advocates. We are frustrated as well, no doubt about it. But insurers are definitely making progress. We believe that this bill would stop a lot of that progress. Since we had last had this conversation right before the pandemic hit in 2020, carriers have made significant strides to improve the situation. Most carriers at the time were not meeting the standards laid out by the MIA to meet the network adequacy standards. We all are now. Since 2018 alone, one carrier in particular has added almost 4,000 providers to the PPO network and 4,000 providers to the HMO network. Carriers are making significant progress. Are we there yet to a situation where we don't have any of these issues? Absolutely not, but we are making progress. Carriers are expanding networks while continuing to innovate in this space. There are new partnerships, expanded and dedicated behavioral health call centers, as well as app triaging. The world is changing and we're changing with it. We will get you an appointment today if you want one. If you get on a crisis line and you need an appointment today, every carrier will find you one today. This committee has added social workers and expanded scope to help alleviate the challenge, but we still have not solved the problem, and we're going to continue to be at the table to try to do so. There are a lot of approaches this year in the General Assembly to address healthcare shortages. We have been saying that in front of this committee for years. The lack of providers in the behavioral health space is a significant hurdle. Just to be crystal clear, there are not enough behavioral health providers in Maryland to meet the needs of the population, and this bill does nothing to address that. For example, even if every single carrier were to contract with every single child psychiatrist on the Eastern Shore, we would still fail to meet the standards of the network adequacy formulas. Unfortunately, carriers can do nothing to solve this. There was a bill that was introduced in 2020 that unfortunately died because of the pandemic that would have given us opportunities to get updated information from all the boards so we could contact and continue to build the networks. Even without that bill, carriers have made tremendous strides, and with that kind of approach, that would help us make even more. This bill, though, looks to mandate payments outside of the network. This is completely counterproductive to the work carriers have made to expand the networks and will take away any incentive from a provider to join the network, which is what we all ultimately want. How do you negotiate a rate if there's a mandated rate? Why would you join a network when you can operate outside of the network and you don't have to deal with the red tape and are guaranteed a payment? For these reasons, we respectfully request an unfavorable report on Senate Bill 707.
We try not to be lazy, Matthew, but if you could find that 2020 bill number for us.
Yeah, it was from Delegate Kelly. I'd be happy to send it over to the committee.
Okay, thank you. Are there other questions? All right, then that ends the testimony on this bill. Okay. Senator Augustine, you're up next for Senate Bill 637, Behavioral Health Services Expansion, Behavioral Health System Modernization Act. Okay, let's see. Call your panel. Dan Martin, Lori Doyle, and Katie Rouse.
Thank you, Madam Chair. Senator Malcolm Augustine here on behalf, asking for a favorable report on Senate Bill 637, which is the Health and Health Insurance Behavioral Health Service Expansion, Behavioral Health System Modernization Act. Colleagues, this bill will expand comprehensive community-based treatment by expanding Maryland's network of certified community behavioral health clinics. It will improve health outcomes and treatment quality by expanding the delivery of individualized, data-driven, measurement-based care in behavioral health settings, and by enhancing care coordination in primary care settings. It will strengthen the behavioral health workforce by expanding funding and reimbursement for peer support networks and certified peer recovery specialists. It will improve care for children and youth by increasing the availability of comprehensive home and community-based wraparound services, and reduce reliance on law enforcement and emergency departments by ensuring stable reimbursement for Maryland's network of crisis call centers, mobile crisis teams, and crisis stabilization facilities. And colleagues, I don't need to reiterate for you all around the behavioral health crisis that we have here in the state of Maryland. We've heard a lot today about access to care for various different things. And what I will share with you is that Maryland has 48 federally designated mental health professional shortage areas, 48, including 16 entire counties where we do not have the number of professionals available to meet the needs of Marylanders with regard to mental health. I will also just share with you, colleagues, that our hospitals saw more than 417,000 visits for behavioral health crises in 2019. Now, this Behavioral Health System Modernization Act will help with that. That's what this will do. Maryland has a good behavioral health system, but with just a few enhancements, we could have a great one. That's what the Behavioral Health System Modernization Act does. It will enact a series of reforms designed to meet the increasing demand and needs that we have. I often talk in here about my interest in investments in our people that will pay off in the long term. They're not easy to do. This is a big bill with a significant fiscal note. There's just no question about it. But what it represents is an opportunity for us to reduce those hospitalizations in crisis, reduce or help with those folks and keep them from becoming incarcerated because their underlying crime is actually undiagnosed mental illness. And we need to get people that care earlier in the process. This is an investment. There's just no doubt about it. But I also think that what's most important and what you're going to hear from here with the panel that we have put together is that it's important for us to listen to the people who are providing the service. And that's what this bill really is about. It's about listening to those experts, the people who are providing this behavioral health care for Marylanders who in their heart would like to see us just do it a little bit better. And that's what this bill has done. I ask for a favorable report on Senate Bill 637. Thank you.
Thank you. Are there any questions? All right. Then in that case, we'll go next to Dan Martin.
Thank you, Madam Chair, members of the committee. Dan Martin with the Mental Health Association of Maryland here to talk about Senate Bill 637, which I think is the most important bill that you guys are going to see and listen to all session, and thank you for hearing us. You know, this is priority legislation this year for the Maryland Behavioral Health Coalition, and I thank you, Senator Augustine, for introducing it. The coalition is upwards of 100 nonprofit organizations across the state now, all working to increase access to mental health and substance use services, and we all put our heads together over the last interim and said, you know, what can we do to really kind of address this increasing demand coming out of the pandemic for mental health and substance use services? And the solution we came up with is this Behavioral Health System Modernization Act. And like Senator Augustine said, what it really does is just implement a series of reforms and enhancements designed to meet the increasing demand, designed to bring our behavioral health system into the 21st century. You know, some of your colleagues that we've been talking to have likened it to a blueprint for behavioral health like we did for education over the past few years. And these reforms aren't groundbreaking or profound. You know, other states are doing these things. We've been talking about them in Maryland for years, but we've just never pushed them over the finish line and enacted them, and that's what we're trying to do here. And I know the fiscal note is big, and I want to speak to that real quickly. You know, we've been hearing bills today. You've been heard bills today about, you know, the low payments going to primary care, you know, the inability just now of people being able to get in-network access to care. And we have a tendency in this state and in this country, whether it's commercial carriers, whether it's Medicare or Medicaid, whether it's primary care or comprehensive outpatient mental health and substance use care, to resist paying for the prevention and early intervention treatments that can keep people out of medical emergencies and that can keep people out of behavioral health crises. And it ends up killing us on the back end, both fiscally and actually killing us on the back end. In ED visits, serious chronic conditions, high-cost procedures, we need to break this cycle and get upstream and prevent more serious and costly sickness and illness. And it's a fiscally sound policy, and it'll save lives, and it'll improve the health of our economy, or health of our society. And so that's what this Behavioral Health System Modernization Act does. Like I said, bring our system into the 21st century. You're going to hear my colleagues on the panel and some coming from behind us that'll talk about some of the specifics of the bill. And so just in the last couple seconds of my time, I just want to talk about one of the pieces. It's the collaborative care model. The bill requires Medicaid to reimburse for the collaborative care model. You know, most people with mild to moderate depression or anxiety don't go to a specialist. They'll go to their primary care doctor for treatment. And too often the treatment in those settings for behavioral health care is inadequate. And so what this collaborative care model does, it's a validated evidence-based approach to improve the delivery of behavioral health care in those settings. An ongoing Maryland Medicaid pilot has demonstrated clinically significant improvement in depression and anxiety symptoms for more than 65% of the participants. And commercial insurers and Medicare in the state are all paying for this collaborative care model, but the inability of large health systems and other primary care providers to bill Medicaid, one of the major payers, has stifled the expansion of that model. And so what this would do, one of the provisions of this bill is it would end that Medicaid pilot and just require them to turn the codes on and start reimbursing for that proven model across the state. And so I'll stop there. I'll turn it over to my colleagues to talk about some of the other specific provisions of the bill. But again, I know it's a high fiscal note, but I don't think we can afford not to move forward with this. So thank you very much for your time.
Thank you. Don't see any questions now. Lori Doyle.
Thank you, Madam Chair. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. I'm here to talk about the Certified Community Behavioral Health Clinics, CCBHCs. It's a federal designation based on the FQHC model to provide comprehensive care to those in need, but focus on behavioral health. A recent 5-year evaluation of the 8 original states, that includes 3 of our neighbors to the north, New York, New Jersey, and Pennsylvania, have showed significant outcomes. You have my testimony and a handout, so I'll only highlight a few. New York, all-cause hospital readmissions dropped 55% after the first year. Missouri, hospitalizations dropped 20% after 3 years, and ED visits dropped 36%. New Jersey, the number of clients receiving medication-assisted treatment for opioid use disorders nearly doubled from year 1 to year 2. These are all outcomes that are consistent with our total cost of care model and our SIHIS goals, so extremely important to the state. We have 5 organizations in Maryland that currently have 2-year grants from the feds to implement CCBHCs. They're in Anne Arundel County, Baltimore City, PG County, and Montgomery County. This bill would require the department to submit a waiver or a state plan amendment to pursue CCBHCs. That process needs to start now so that we don't lose all of the time and effort that has gone into the implementation of these CCBHC grants. And I'll close really by just noting the fiscal note. There are a lot of reasons why that is highly inflated in terms of the CCBHCs. Most of these services are Medicaid funded, and the state can determine what CCBHCs do in accordance with their state plan. I just hope that the number that they're quoting in that fiscal note is not a reflection of the department's assessment of the underfunding for behavioral health. It is significant. And so I would say that, CCBHCs in this bill are like roads and bridges. It's not sexy stuff, but it is critical and necessary stuff. And so we appreciate you taking a look at it, and I hope you will give it your support. Thank you.
Thank you. Don't see any lights. Okay, so we'll go to Katie Ross.
Good afternoon. Thank you so much, Madam Chair, Vice Chair, and committee members for all of your dedicated service and for your time and attention today. I'm Katie Rouse. I'm the Executive Director of Honor and of Maryland, and we support a statewide network of wellness and recovery centers that offer free walk-in recovery support services to more than 5,000 folks across the state every year. All of our centers are run by and for people with lived experience of mental health and substance use challenges, and the investment that this bill will provide is going to be transformative. Almost 40 years ago, the very first center for On Our Own network opened in Baltimore, and it launched what will become a network of thousands of folks who have created communities of wellness and support and recovery. And we're particularly good at connecting with folks who are unhoused, uninsured, or who are too often labeled as being hard to reach or difficult to serve because they're dealing with complicated challenges. But the support and the skills and the sense of belonging and understanding that people get through centers like ours and from peer support specialists working in other clinical settings really can make the difference between life and death. Our centers operate on shoestring budgets, often less than $150,000 a year, funded through the Behavioral Health Administration. But each responds to the local needs, whether that's a reentry support program in Western Maryland or home visits on the Lower Eastern Shore. We are innovative, we are flexible, we are responsive, and we're able to dedicate every available dollar to delivering direct services in communities. And a huge part of why we can do that is because we have predictable annualized funding through grants and contracts, and we're not tied to the fee-for-service system, which is antithetical to our effectiveness and our values as peer-run services. But no matter where peers are, we are cost saving. We decrease utilization of high intensity services and emergency services because we increase people's capacity to self-manage. And now is really the ideal time to invest in peers and peer support. Not only because we're providing essential services to people every day, especially folks really on the fringes, but we're also building up the next generation of healthcare providers as certified peer recovery specialists and as thought leaders and change agents who are eager to join the behavioral health system even as others are leaving. So Senate Bill 637 is putting funding directly into programs and services that were created by peers for our communities and that really honor the fact that respect is mutual, that choice is essential, and that recovery is a journey that everyone can make. So we strongly encourage you to pass this bill, and thank you for your time.
Thank you. Are there any questions? Okay, if not, then we're going next to the following persons who will have 2 minutes each. Ann Geddes, Dan Rabbit, Haley Rizcala, and Carrie Cho. Okay. If Carrie Cho is not here, is Ann Seacott here? All right, Ann.
I'm Carrie Cho.
Okay, all right, okay. Well, somebody. Okay. You may start.
All right, thank you, Madam Chair and committee members.
You have 2 minutes each.
Yep, my name is Ann Geddes. Again, I'm with Maryland Coalition of Families, and I'm here in support of Senate Bill 637. Specifically, I want to talk about the portion of 637 that aims to strengthen the targeted case management and 1959 programs for children and youth. These two programs were intended to be the pillars of home and community-based services for children and youth in Maryland. They are based on the wraparound model of service delivery, which is the gold standard for treating children and adolescents with more intensive mental health needs. Unfortunately, there have been a number of problems with these programs. Low enrollment numbers, 2019 reported 35 youth enrolled in the 1915I. Limited numbers of providers, underutilization of evidence-based practices, and low satisfaction with the services by families all have contributed to the weaknesses of the program. Senate Bill 637 would do 5 things to strengthen the TCM and 1959 programs. It would require that care coordinators be trained in the delivery of high-fidelity wraparound and that providers be reimbursed at adequate rates for this service. This would improve the quality of the service. It would require that providers of evidence-based practices be reimbursed at rates commensurate with industry standards. Currently, the rate for family-centered treatment, for example, is about 1/2 of what DJS pays for the same service. Adequate rates would promote the use of evidence-based practices. It would establish adequate funding in BHA's budget for customized goods services, which is one of the benefits of the programs, for things such as equine therapy, art therapy, martial arts classes, things that are not covered by Medicaid but can do much to promote a youth's recovery. I just want to add regarding the fiscal note, BHA already pays for customized goods and services. In FY21, they spent $143 on the resource. The bill would also expand the number of slots for non-Medicaid eligible youth from 50 to 100. There are currently waiting lists for those slots, and it would require that BHA look to loosening the eligibility criteria so that more youth can take advantage of the programs and expand the programs to serve youth with substance use disorders. The shortage of residential treatment beds for kids and the problem of kids stuck in emergency departments and hospitals can in part be attributed to the lack of robust home and community-based services in Maryland. By strengthening the TCM and 1915I programs, the legislature will go some way to addressing the bed crisis. We urge a favorable report on Senate Bill 637.
Okay, thank you very much. We'll now go to Dan Rabbit.
Thank you, Madam Chair. Dan Rabbit, I'm with the Policy Director at Behavioral Health System Baltimore. We're the local behavioral health authority for Baltimore City. We stand in strong support of SB 637. You have a written testimony that goes into more depth, but today I want to focus my remarks on the provisions that require reimbursement for behavioral health crisis response services. Behavioral health crises like suicidal ideation or a bipolar episode are a part of mental health and substance use disorders, and unfortunately they're on the rise. Suicide is the second leading cause of death of young people. There's evidence that shows suicide deaths have doubled for Black Marylanders, and Maryland has close to the highest rate of overdose death in the country. Behavioral health crisis response services are key to reversing these trends. The traditional EMS system of 911, ambulances, law enforcement intervention, and emergency room visits are not designed to respond to mental health or substance use crises. 911 is meant to quickly determine the situation and dispatch services. Ambulances and law enforcement intervention often result in being strapped to a stretcher or handcuffed and put into a police car. Going to the emergency room, the emergency rooms are loud and chaotic. You have to wait for hours or days, and you can feel very isolated and dismissed as medical professionals are having to deal with other concerns. We need an alternative system for mental health crises, and we have one. We have one that works. Call centers, mobile crisis response teams, and crisis stabilization centers are effective, and they're available in some places in the state, but they're not consistently available whenever anyone needs them. A big part of that is because they are not reimbursable. And SB 637 would mandate that Medicaid and private insurance reimburse for those services. It's a good investment. Crisis services save money that would otherwise be spent by going to the emergency room or going to higher levels of care. The HSCRC thought investing in crisis services through their regional catalyst grants was one of the highest values investments they could make to reduce hospital costs. That's why they chose crisis services for that grant program. It led to the Greater Baltimore Regional Integrated Crisis System, GBRICS, that you may have heard of, that BHSB is helping to manage, as well as several other pilots. And they wouldn't have picked that if that wasn't a good way to reduce the total cost of care. So crisis services can bring down costs. There's also significant federal funding that's available if we choose to fund crisis services through Medicaid. The American Rescue Plan provides an 85% match for mobile crisis response teams for 3 years, and we should take advantage of that. So in closing, Just want to say that providing insurance reimbursement for crisis services makes good clinical sense. It will improve care for people who are experiencing serious challenges, but it also makes good fiscal sense, and it's a sound investment. We urge a favorable report.
Okay. As far as you are aware, are we making much use of this American Rescue Plan here in Maryland?
So the state of Maryland did seek a planning grant to consider it, but the state of Maryland sought out planning grants in the past and not gone on to pursue a state plan amendment or Medicaid financing. And so we think that this is too important to leave up to the discretion of future administrations.
Was the original attempt way back in time or fairly recent?
Fairly recently, not specifically for this, but for other opportunities in the Medicaid program, specifically for crisis services. I know the state looked at reimbursing crisis stabilization centers through Medicaid, and they got a planning grant, and they convened a coalition for several years, and there still hasn't been any movement on actually pursuing reimbursement.
Okay. Thank you.
Thank you.
Let's go to Carrie Cho. Oh, did we go to Hallie?
She's not here.
Okay, not here. Okay, Carrie Cho.
Okay. Good afternoon. Thank you, Madam Chair and members of the committee. My name is Carrie Guthrie Cho, and I am the CEO of Cornerstone Montgomery, the largest behavioral health provider in Montgomery County. I'm going to focus my testimony on the Certified Community Behavioral Health Center model. Cornerstone Montgomery has been a CCBHC since 2018 through 2 SAMHSA grants. We were one of the first to get one of those in the state, and this has allowed us to better serve the residents of Montgomery County. Since becoming a CCBHC, we have added 1,098 clients to our programs, including a second assertive community treatment team. By expanding these services, we have seen emergency department visits drop by 59% and hospitalizations drop by 36%. In our ACT program alone, we have saved the state over $2 million in hospitalizations. As a CCBHC, we were able to add CNAs and LPNs to our residential program to help clients address the co-occurring medical issues that research shows lead to them dying 20 years earlier than the rest of the general population. Over the last 4 years as a CCBHC, nearly 400 clients have received services from a CNA or an LPN for things like personal hygiene, nutrition, and most importantly, medical follow-up. As a CCBHC, we expanded our outpatient clinic to begin serving children 12 and older, and we have also implemented an on-demand video translation software to meet the needs of our very diverse community. We served an additional 45 clients who speak 21 different languages, including sign language, Amharic, Arabic, and Cantonese. Sign language by far being the most common that we used in the last year. We provide services to many who are dually diagnosed with mental health and substance use disorders under our mental health accreditation, but with the CCBHC funds, we are going to be able to expand and become accredited as a substance use disorder provider, which means we'll be able to serve a lot more people. As a CCBHC, we have expanded these services to better serve the growing needs of our community. It is time for Maryland to invest in the lives of our most vulnerable and to catch up with the rest of the country and implement and fund CCBHCs. We respectfully request a favorable report on Senate Bill 637. Thank you.
Thank you. That was chock full of interesting information.
And there's a
Okay.
lot more data in my written testimony.
Okay. Ann Seacott.
Thank you. Thank you, Madam Chair, members of the committee. Ann Seacott, representing the Maryland chapter of the National Council on Alcoholism and Drug Dependence, in strong support of Senate Bill 637. I want to talk about the section in the bill related to peers. That section actually has 2 pieces to it. And unlike how the fiscal note assumes that the funding kind of bleeds over into both areas, please be clear, the intent of the legislation is that there would be grant funding for peer services separate from the mandate that peer services be reimbursed by insurance. And this has to do with the fact that not all services are necessarily appropriate to be reimbursed by Medicaid, and that there are programs that provide services, as you heard earlier from Ms. Rouse, totally run by peers, and those are not clinical settings where they have the infrastructure, the funding to be able to do billing for Medicaid. So we want to make sure that's very clear. Those are two separate asks. We appreciate some feedback from Care First around understanding some of the issues related to how we might make this work when it comes to private insurance coverage. And I want to acknowledge, as it is in the fiscal note, the Maryland Medicaid has just recently finally decided it is going to move forward with Medicaid reimbursement for peers. And they have identified $24 million associated with some of the federal aid that's come to the state. And we are very excited to work with them on how to make it work. And I will also say that we want to make sure that we're supporting peers in all kinds of settings. I think there might be a limitation in how they're thinking about it right now. And I want to say that we are absolutely supportive of making sure that we are serving people with both mental health disorders, substance use disorders, and co-occurring disorders, and that we should not arbitrarily continue to bifurcate people and programs. It's the whole purpose of bringing together the Behavioral Health Administration. I will close by saying, when else are we going to do this kind of investment? We are hearing these horrific stories and data related to unmet need. Given the kind of fiscal shape that we're in right now, when else are we going to make this kind of investment that we know these fiscal notes don't reflect the savings that we achieve when we invest in these services? Now is the time for this kind of big, bold measure. We urge a favorable report.
Thank you. Well, I don't see any lights, so we'll call up the next panel. DePaul Niebuhr, Belina Shaw, J.B. Moore, and Natalie Bussac. And I apologize if I'm messing up someone's name. Okay.
Pretty spot on for my name.
All right, okay, and you're going to have 2 minutes each.
Good afternoon, Madam Chair, Mr. Vice Chair, and members of the committee. My name is DePaul Nibber. I'm representing the Maryland Association of Counties in support of SB 637. As you've already heard, the behavioral health interventions at the heart of this bill are public health best practices. Our counties have championed many of these practices over the years, including standing up the state's first crisis intervention teams and stabilization centers. What this bill does is essentially create a more sustainable funding mechanism, whether through Medicaid or through private insurance reimbursement, to ensure these programs and services endure. So, in short, Senate Bill 637 is instrumental to preventing great suffering and loss of life. It will help proactively address deteriorating mental health as a result of the pandemic and the worsening opioid overdose crisis. For this reason, MACO urges a favorable report for Senate Bill 637. Thank you.
Thank you. Any questions? Okay. Belina Shaw.
Chairwoman Kelly, members of the Finance Committee, thank you for the opportunity to testify today. I'm Dr. Belina Shaw. I'm a triple board certified physician in the specialties of child and adolescent psychiatry, adult psychiatry, and addiction medicine. I serve as the medical director of the Behavioral Health Division at the Prince George's County Health Department. I'm here to express strong support for Senate Bill 637 on behalf of Prince George's County, and would like to thank Senator Augustine for his timeless commitment to behavioral health services. As physicians, we are taught not to order a test if the results will not change our management. For example, why would you order an X-ray if you're not planning on casting a broken limb? So behavioral health service delivery is no different. The imminent federal designation of 988 for behavioral health crisis services will lead to an anticipated 3- to 5-fold increase in calls. If we do not create a sustainable system to meet this demand, it's like doing thousands of new X-rays without being able to mend the broken bones we find. Without stable funding streams for behavioral health crisis services, citizens will call a hotline that does not have anything to immediately help them. Well, Prince George's County is the recipient of a nearly $23 million grant through TLCMD from the Health Services Cost Review Commission that Dan mentioned, and it's anchored by plans for the state's first crisis receiving and stabilization center that aligns with the federal best practice guidelines. And such a system can save money over time. But comprehensive crisis services must be urgently codified as part of Maryland's Medicaid and private insurance plans in order for us to start creating a system that will be able to last. Marylanders deserve to be able to call 988, receive an X-ray into their life's challenges, and have access to critical resources to facilitate healing. Prince George's County supports SB 637 and urges the committee for a favorable report.
Okay, are there any questions? Okay, thank you very much, Doctor. We're going next to Kevin Keegan. Oh, I'm sorry, to J.B. Moore.
Is it on? Good afternoon, Chair Kelly, Vice Chair Feldman, and distinguished members. On behalf of NAMI Prince George's County, I extend gratitude for the opportunity to support HB 637. I am J.B. Moore, Executive Director for NAMI Prince George's County, family member and guardian for a loved one living with a serious mental illness. I'm also a Desert Storm Gulf War veteran. We applaud Senator Augustine's dedicated efforts to address critical issues surrounding mental health and substance use and for his wholehearted support for NAMI. Public-private partnerships, such as the one that exists in Prince George's County, because of the Health Services Cost Review Commission's Regional Catalyst Grant Program, greatly benefits the county. The program model encourages hospitals to work with community partners to build important foundations to improve population health, especially in underserved communities, where disadvantaged communities where gaps in services drive inequality. The county is a majority Black jurisdiction with a fast-growing Latino and immigrant population. Some areas in the county have limited access to behavioral health services. These are known as treatment deserts, and the county has one of the highest rates of uninsured residents in the state. Prior to the county's Catalyst Grant, there were only 2 crisis teams, mobile crisis teams, serving a county of nearly 1 million residents. Some communities in the county overutilize emergency room services and create an undue burden on health care costs for the county as well as for the state. Overly expensive emergency rooms serve as safety nets for many Prince Georgians who cannot get care anywhere else. Emergency departments are responsible for many hospital admissions in the county. This is many of these costly hospital stays can be avoided by targeting preventable hospital utilizations. This is exactly what the Catalyst Grant Program allows the county to do by expanding the county's crisis infrastructure and developing effective strategies for sustainable crisis response services. Unfortunately, the Catalyst Grant Program is only a temporary funding mechanism. And despite the noteworthy efforts of the county government, sustainability of these expansion efforts will require reliable reimbursement beyond the grant terms. Medicaid and private insurance companies must be required to subsidize the cost of these crisis response services. All Marylanders should receive the mental health and substance use care they need and deserve. SB 637 is important to Prince George's County families and to the thousands of families across this great state of Maryland. NAMI urges this committee to pass SB 637. Thank you.
Thank you. Senator Augustine.
I'll be brief, but Madam Chair, I just have to say, and Senator Benson, this is for you too. JB, Ms. Moore is the resource that I go to when we have, when I get calls from constituents in a behavioral health crisis. And she's the one who answers my call to help the people of Prince George's County when I don't know where to turn. I turn to her. and I'm grateful for that. We also turned to her when I tried to talk to other elected officials in my district, 47, we had the loss of a mayor to suicide. And so I brought our folks together and asked Ms. Moore to help us bring some professional to talk to us about grief, to talk to us about how we as elected officials have these extra burdens that people come to us with, and how do we deal with those things. And she's the one who provided the resource, who was there to come and talk to us. And so I just want to say thank you to you for that. I'm really grateful. Thank you so much.
You sound like a very valuable resource. Okay. We're going next to Natalie Boussac.
Thank you, Chair Kelly, Vice Chair Feldman, and members of the committee. As you know, my name is Natalie Boussac. I'm a health policy intern with Senator Augustine's office, but I'm here as a constituent of Maryland and a consumer of behavioral health services. We've heard a lot of talk about stigma and the barrier of stigma, and I just want to emphasize that there are so many stories of resilience that are hiding in plain sight because stigma hides the success stories. That's why peer support is so effective, because there is power in knowing that the person in front of you has been in that same pit and they know the way out. When you have your behavioral health needs and your primary care needs met in the same place, such as through the collaborative care model and with CCBHCs, it normalizes seeking care for mental health and substance use the same way we would seek care for any other aspect of our health. For these reasons, I urge a favorable report of SB 637. Thank you.
Thank you. Congratulations on being an intern here. Okay.
Madam Chair?
Yes.
I just wanted to say this because I just had over another committee, one of my bills where I brought my intern from University of Maryland to testify. He testified on a bill with me. And I just really encourage, I think it's great to see you, Natalie, you're doing a great job. And I just, want to echo the idea. I love the idea that we can incorporate some folks from our office in the process. So I thank you. I commend Senator Augustine for including you on some of these bills. So that's all I had to say. Thank you.
Okay, that's very important. All right. I think we've gotten to everybody on this panel, did we? All right. We're going next to Kevin Keegan. And we'll take Kathy Grayson. Is she here?
Thank you, Madam Chair. Members of the committee, my name is Kevin Keegan, and I am the Division Director for the Family Services Division at Catholic Charities in Baltimore. We provide homeless shelters, we provide Safe Streets programs, we provide outpatient mental health centers that will also include substance use treatment, which includes medication-assisted treatment. And I feel bad for even being here because I think Natalie should have been the cleanup hitter, and just because honestly what she said is really what it's all about. We work, as I described in those programs, just with some of the most vulnerable individuals you'll ever come across, at incredible risk of being victimized, and sadly, as we see in our Safe Streets programs, incredibly at risk at sometimes being the perpetrator or victimizing others. And our Safe Streets director says it best when he tells me that hurt people, and that, you've all heard that before, but it's so meaningful. And what strikes me about this bill, I love the behavioral health modernization, because, this isn't the old behavioral health system that we need anymore. We can't just hang out a shingle and expect that somebody who's living in Sandtown, Winchester, in West Baltimore to come get treatment because they believe they've been traumatized. It just doesn't translate. And when you talk about modernization, we usually think about technology and such, but it's not about, this is actually about doing things in a way that our modern world receives, because we can be really great at doing therapy, but if nobody comes to us, then what's the point, right? So the reality is what this bill does, Natalie described peers so well that it brought tears to my eyes. That's exactly what peers do. This is why we talk about CCBHC models, because it actually brings all those pieces together and tries to take care of all your needs while you're there. Crisis services are about meeting somebody's needs at that exact moment when they're receptive to it, when they're at their most challenging times. You know, we talk about community-based services and 1915I. It's actually about community-based care. It's about schools. It's about seeing children in schools, seeing families in schools. It's about being right in the family's living room when they need it and working with them on how we keep kids from going into foster care or whatever that is. So the reason why I believe we should support this bill is it modernizes our system in a way that connects to people who need our care, who aren't going to come to it in an old way of doing things. And I respectfully urge support for this bill. I thank the senator to no end about putting this bill in, and thank you very much for your time.
Thank you. All right, and next we're coming to Kathy Grayson. She's favorable with an amendment.
Thank you so much, Madam Chair. Kathy Grayson here today on behalf of Care First Blue Cross Blue Shield. We are favorable with amendments on this bill. I want to start out by echoing the gratitude for Senator Augustine. Your leadership on behavioral health just can't be overstated, and I hope you know that we want to be a partner with you in that effort and help figure out how that fits into the commercial payer space, but also into the community space, you know, because improving behavioral health access for our members in the communities we serve is essential to our mission. So I want to limit my comments really to operational issues that we've identified, starting on page 8 of the bill, the amendments to the insurance article. So Care First is actually a member of the GBRICS Council that was referenced a few times, one of the behavioral health catalyst grantees from the HSCRC, and we are firm believers in the need for a robust and effective crisis response system. As the gentleman before me so beautifully articulated, the need to give a member someone to call, someone who can go out, meet them where they are from a mental health context, and then give them somewhere to go and do it in an appropriate way that's not focused on law enforcement and emergency rooms, but focused on behavioral health needs. And so just Care First wants to applaud the partners that have come before, and these are the people on the ground doing this work. And it's absolutely critical, and we absolutely support it. We want to mention, when we talk about in this bill, translating a process and programs that are today largely grant funded or public funded into the commercial space, it's absolutely something we need to do and look at, but there are operational questions, and they haven't quite been sorted through. I've had some great conversations with advocates in the last week, but let me give you just a few examples. So certified peer recovery specialists in the Health General Code are certified and overseen by behavioral health programs. And Medicaid reimburses programs, and grants give money to programs. But in the commercial space, we reimburse licensed providers that submit claim codes. So we don't have programs in our network. For example, we have providers. So we need to take a look at the certification standards for peer recovery specialists and think through how that fits into a commercial reimbursement structure, because today it does not under the certification protocol. Second, there's a couple of mandates in the bill. In addition to coverage for those providers, it's coverage for behavioral health crisis response services. The way it's laid out in the bill is somewhat conceptual, because when you talk to some of these wonderful groups that came before, you'll hear about how multifaceted their programs are and how they rely on a large array of partnerships from the beginning of the crisis to the end to help members. So I've been learning about some of the codes that I discussed. You know, providers submit codes for reimbursement, and I'm pleased to report Care First is covering a lot of this today, and I suspect some of our colleagues in the industry are as well. However, again, without articulating who's performing the service, and is it up through a licensed provider that can submit the claim code, and then what is the specific claim code, that's the conversation that we need to continue having so that we can figure out how to translate this grant-funded public model into the commercial space. And then lastly, measurement-based care. And again, we've talked about who's providing what are they providing and who is submitting the claim. Measurement-based care is sort of a care philosophy that entails, among other things, completion of a questionnaire and evaluation over time with a provider. We cover that claim code when it's submitted by a provider, but the bill talks conceptually about measurement-based care. So again, I think these are technical issues, and I really think that there are solutions, but we probably need to have a longer conversation with stakeholders to just really understand what needs to be covered. Are we doing it today? Where are the gaps? And then again, how do we translate the provider pipeline in a way that makes sense, where the commercial market really focuses on a provider license at the top, overseeing an array of professionals. So with that, we just again thank the proponents. Really phenomenal work that you all are doing, and I'm happy to have these conversations and answer any questions. Thank you.
Okay. That was great information. Thank you very much. And our final witness is Matthew Celentano for the League of Life and Health Insurers.
You might be surprised. Good afternoon. This is a weird way to come back into this room after 2 years, but here we are. Matt Celentano here today on behalf of the League of Life and Health Insurers. Opposed to the bill as introduced, but absolutely not opposed to the model and the approach to modernizing behavioral health. I'm not going to reiterate most of what my colleague, Ms. Grayson, said. I think what she said is the majority of my concerns. I probably should have come in with a different position, but Senator Augustine, we are certainly willing to work with you on this bill. Our problems are mostly operational. It's basically trying to force a square peg into a round hole. That doesn't mean that it's not worthy and we shouldn't continue to have the conversation, but it's not set up for an insurance model. The first thing is the peer recovery specialist. Nobody is going to say that we're not thinking that these are valuable services or an approach that we should be doing, but the problem is the folks have no certification and they don't report to a licensed provider. So without that oversight, we can't even reimburse the people. In addition to the payment mechanism, without the oversight, there's no consumer protection, which is of concern to the carriers. So those sort of some things like that. The same thing with measurement-based care. It implies it's based on evidence-based care, but in the way it works in the insurance article, it's not really. The language is foggy, it's ambiguous, and we'd like to further define that. Like I said, we are not against the concept. We are just opposed to the bill as introduced, but we would be certainly willing to work with the sponsor and the stakeholders.
Would you say that maybe you, Care First, and a couple of the major providers working with the sponsor might get this done?
We would be happy to talk about this bill for sure. I can't speak to the beginning part of the bill, which is the monetary side of it, but that is not my area.
Okay. Thank you.
I didn't say that. You said it's under. No, it is a great idea. We'll be willing to work on it for sure.
Okay. Are there any other questions? All right. If not, then that ends our bill hearing for today. And